There we go.
Croeso i bawb i gyfarfod Bwrdd Ymddiriedolaeth Gwasanaeth Iechyd Gwladol Prifysgol Felindre. Welcome all to Felindre University NHS Trust Board meeting. Fel aelod o'r cyhoedd, gallwch fynychu'r cyfarfod i arsylwi. Mae hynny'n golygu y gallwch weld a chlywed y cyfarfod, ond ni chewch gyfrannu. Rydym yn recordio'r cyfarfod a bydd cofnod ohono ar gael ar ein gwefan yn fuan. O ganlyniad, gofynnwn yn garedig i chi beidio a recordio'r cyfarfod os gwelwch yn dda. As a member of the public, you can attend the meeting as an observer. That means that you can see and hear the discussion, but cannot participate. We intend to provide a video recording of the meeting, which will be available on the website soon after. For that reason, we ask that you do not record the meeting yourself. Hoffwn gyflwyno aelodau annibynnol o'r bwrdd. I would like to introduce the independent members of the board. A'r prifweithredwr ac aelodau gweithredol ac anweithredol o'r bwrdd. And the board chief executive, executive and non-executive board members. Hoffwn gyflwyno nawr gadeirydd y bwrdd, yr athro Donna Mead OBE. I would now like to introduce the chair, Professor Donna Mead OBE.
Bore da pawb, o croeso cynnes iawn i chi gyd i'r cyfarfod bwrdd hwn heddiw. Good morning everybody and a very warm welcome to this board meeting today. Y bwrdd hwn yw cyntaf yn y blwyddyn hon ac mae'n dal i fod yn Ionawr, felly blwyddyn newydd dda. This is the first board meeting of the year, therefore I think it's okay to say Happy New Year. Y cyfarfod hwn yn pwysig achos mae cyfarfod cyntaf ein prif weithredw newydd, David Donegan. Croeso cynnes iawn i David a dymuniadau gorau. So this is an important board meeting also because it's the first meeting of our new, or maybe not quite so new, Chief Executive David Donegan, and I want to send our very best wishes to David in his new role. I'll continue in English at this point. As you've heard, this meeting is being live streamed for those who are joining remotely, and the recording of the meeting will be available on the Trust website if members of the public or our staff wish to view the recording at their convenience. I'd like to welcome Bethan Davis and diolch i ti for providing the simultaneous Welsh translation service for this meeting. And so to everybody that's joined this board meeting, welcome. The meeting is being recorded for minute-taking purposes as well as you will have heard at the outset. The process with this meeting is being held live in the boardroom at the Trust headquarters, and a number of colleagues have joined us remotely. Thank you to Stephen Harries, who's joined us from his holiday. So therefore, use your electronic hand if you're joining us via Teams, and the usual raise your hand in the meeting, and I will do my very best to ensure that I call people in the order that I spot them, either raising their actual hand or their electronic hand. I'll do my best, and none on my right hand side you will help me with that. But shout out if I missed anybody. It wouldn't be my intention to do that. To miss anybody out. So if we could come to 1.10, which is welcome and apologies. I've received apologies from Alan Prosser and David Cogan, our patient representative. Anybody aware of any other apologies that I don't have? No? Thank you. So there will be a number of people in attendance. Katrina February from Audit Wales. Are you there already, Katrina? Kate, yes. Kate, I can see Kate. Emma Rees, Deputy Head of Internal Audit from Shared Services. Rachel Hennessy, I can see Rachel, our Interim Director of Elindra Cancer Services. Peter Groves and Lisa King will be joining us, I think, later in the meeting for the item in relation to Health Technology Wales. And do we have Paige Jennings Brooksby? Paige, are you with us? Hi, Paige. Who's our management graduate trainee who's here to observe. Paige, if you've got any queries, don't feel shy about raising your hands and I'll call you into the meeting. So, does everybody know everybody? David, do you know everybody around the table?
Yes.
Yes, okay. Does everybody, do I need to do any introductions? I don't think so. So that being said, if I can take you now to 1.30 declarations of interest. There's one final thing I wanted to say before getting down to business and brass tacks. Llongyfarchiadau I Gareth Jones am y baba newydd. Gareth. Gareth became a grandfather again, I think, a few days ago. Is that right, Gareth?
Yeah, thank you, Chair. Mother and baby doing well, and glad to see the new arrival.
Wonderful. So 1.30, are there any declarations of interest pertinent to the items on the agenda today which haven't previously been declared? The opportunity to declare them now, please. No? Thank you. So if I can go to 1.4.0, which is the minutes of the meeting that was held on the 28th of November. I wasn't present at that meeting. I think it's one of the only board meetings I've missed. Stephen Harries, our Vice Chair, very kindly chaired that meeting. So Stephen, I will be asking you to, if there are any corrections that people wish to make, if Stephen, you would verify those for me, please. But are there any corrections to the minutes? No, so thank you very much. So that means we accept the minutes as an accurate record of the meeting held on the 28th of November. If we can go to 1.50, which is the action log. Is the board content to confirm that actions marked as closed are an accurate reflection of the position? I can see nods, so that's great. Reactions which remain open, would each exec director speak to the open actions for which they have responsibility, but noting action 2.10 from the 28th of the 11th 24, read Colonel Simon Lawrence, a letter was sent by me as soon as I was informed of the medal. So that action actually took place before the board meeting. So that action is closed. I'd already, as chair, sent a letter congratulating Simon. So if we can mark that as closed, please. And so if we can now go to the open actions. And I invite each exec director to speak to the actions for which they are responsible.
Shall I start?
Yeah, please. I'm just loading up here.
Okay.
Right, non. Diolch yn fawr.
Okay. So, with regards to action 3, revisions to the Trust Board Committee's standing orders, that action is dependent on the Corporate Governance Manual as it stands currently, which hasn't yet been approved by the Audit Committee. So I am now considering alternative ways and routes to make sure that that dependency doesn't delay us any further. So I didn't want to close that action, but I think it would need for me to explain that we do need to find an alternative route for that now.
So we are in fact acting it, but the final kind of governance process,
yeah,
will come forward in due course.
Yes,
Thank you,
absolutely.
Norm.
With regards to number 18, we have
18.
now closed that.
Yeah.
And now moving on to number 19 on the trust risk register, so the inclusion of the target rating. That is an active discussion we're having at the moment. The focus on updating and improving what we present in terms of risk has been elsewhere for the last reporting period, and we can get into further detail on that when we come to the risk register item. But this is going to be an inclusion that we will include from the next reporting cycle onwards. So that has also been captured in the governance assurance risk programme.
Thank you, Norm.
They just come in.
Oh, sorry, Lindsay.
And apologies, Norm, but it kind of takes us to 23 as well.
Yeah.
So that's having a target date for reaching the target rating. So
Yes.
23 says the same thing, but I think because I raised that at the last meeting, that was about the box on the tap, which is about the risk or trend.
Yes, at the top.
So just to note, otherwise it looks like we're repeating the action.
Right.
23. But it's a different point.
Yes.
Yeah.
Yes. That's
So
fine.
one is for the risk register, one is for TAF. That distinguishes two of them. Is that what you're saying, Lindsay? Just
Yes,
to be clear,
it's
okay.
a slight, it's a nuance, I think, isn't it? So
yeah.
both
Okay.
require updates to the general scores. We explain them and describe them differently in both registers. Yes.
Yeah.
Okay. Is that me?
So that was
And then I'll move on to number 20, which has been actioned, and you will see updates, certainly from Belinda. Oh, sorry.
somebody's hand. Is up?
Gareth.
Oh, sorry, Gareth. Hello.
Thank you, Chair, and apologies. I'm not sure whether the Welsh translation is working now or not. So,
I do think it is working. So, yeah.
right. Okay.
Okay.
Diolch Cadeirydd. Just yn mynd nôl at weithrediad 3, os gwelwch yn dda, just i fod yn glir, mae'r Corporate Governance Manual, mae pobl yn gweithio ar hwnna ar y funed, a dyw e heb ddod i'r pwyllgor archwilio i gael ei gymardwyo yn ffurfiol. Felly dwi ddim eisiau unrhyw un feddwl fod y pwyllgor archwilio heb wneud ei waith yn gywir.
Na.
Just fod e heb ddod i'r pwyllgor yna eto i gael ei gymardwyo.
Diolch, Gareth. Non?
Ie, na, yn hollol iawn. Fe na i adolygu y geiriad i sicrhau bod e'n adlewyrchu'r sefyllfa fel ddisgrifio chi nawr, Gareth.
Diolch yn fawr.
Okay, so thank you. That was number VV number 20. I'll get it all on one screen here. So
21, I think.
21 dashboard in red for ease of reading. We're closing that one and we've agreed the closure. So the next one is 23.
Which
we've discussed.
Yes.
And the next one then is 25. Is no hands up? 25. Inconsistency delivery date and updates.
25 is review.
I'm going to have to make this lower on my screen. I can't see it. Now I can't read it. 25 is for, so we're all the way down now to action number 30, aren't we?
Yeah.
Okay, thank you. Which is inconsistencies in dates within the paper require correction prior to circulation.
This is with that.
Yeah. This required quite a bit of forensics, Chair. It was a WBS trust procurement that was aligning with a national procurement. And we needed to do a local bridge procurement, is the way I'm going to describe it, to fit with the two national procurements. And there was a discrepancy in the dates. We spent a lot of time going through this with shared services, who confirmed at the beginning of this week that there was a gap. So we now need to govern that through the board, which we will do.
Okay. So that remains open then
Yes.
until that
Yes.
action is completed.
Yeah.
Yeah, but we've got that update. Thank you, Anne. I can't see any other queries, so I propose we accept this action log and note those actions which have been closed and the update to those actions that are remain open. So if I go to 1.60, are there any matters arising from the minutes which were not included in the action log which colleagues wish to raise? No, thank you. So we now come to section 2 of the report, which of the agenda, which is key reports, and the first one there is the chair's update. Although December is usually quite a quiet month, there's still a lot of activity that's been reported in my chair's report, and I'll take any questions for the items that are listed there. I would want to put on record our congratulations to all our colleagues, either fundraisers or staff, that were recognised in the King's New Year's Honours list. I know the Chief Exec is going to do similar in his report. They have all been written to on behalf of the board to be congratulated, just to put that on the record, and we're so very proud of all their achievements. But I'll take questions on any of the matters that I've contained in my report. Already? Can't see any hands up. So we note that report, thank you very much. And then we come to 2.2, which is, and this is the last time I'm going to say this, our new Chief Executive's report. David.
Diolch, Donna Borda. Dewey David, the new Chief Executive, is there, or the Chief Executive from today of Velindre. I'll take the report as read and just maybe summarise in saying that I've just been really, really impressed across our Welsh Blood Service, our Velindre Cancer Service, Health Technology Wales, Shared Services, and all of the other parts of the organisation that are supporting patients and services across Wales. It's been very impressive, and also been impressive how people have risen to engage with me, reflect, and just the palpable sense of appetite there are to continue the good work that's been going on for years, but to continue to improve our services and performance. I'll just throw out two things, if I may. The first would be the fact that it was very pleasing to attend my first JET meeting with Welsh Government, where they review every 6 months their outlook on the trust and its performance. We've received formal correspondence from Welsh Government following that, which confirms that we are in a very good position and quite well regarded across the balanced scorecard of performance domains by Welsh Government. And notwithstanding a shared understanding of risks and challenges, that was very, very positive feedback for everyone in our organisation to have had officially in December. And then, as you say, Chair, there is a number of people who are listed in the report who have been the recipients of achievements or awards that I would like to particularly congratulate everyone who's named in those reports, and thank you for everything you do, and look forward to working with you over the coming years. Happy to take questions.
Are there any questions for David? No. So thank you, David, and we note that report. Section 3 is integrated governance, and we don't today have any papers in that section. So we come to section 4, which is the risk register. So I'd like to just make a few comments before inviting Non to speak. I read this risk register in great detail, and I'd like to acknowledge and welcome the development in the risk register since the last board meeting. It's becoming more informative. I particularly welcome the updates provided which have occurred since the risk register was produced, and hope to see that as a consistent feature going forward. I'm pleased to note the areas of duplication which have been removed. There remains a need, as we noted in the action log, to ensure that we have smarter actions, and I know that the team are working hard on this. Having said all that, as just by way of introduction, I'm going to ask Non, as interim director and accountable for the risk register during the reporting period, to take us through the risk register, and that process allows the board to have effective oversight and assurance of the way in which the risks are being reported and managed across the Trust, in addition to the ongoing activity related to the status of the risks and the mitigation. And just as an MB, what we've included at the board is risk scoring 12 and above for quality and safety, and then 15 and above for all other risks. Non.
Diolch yn fawr iawn. Dwi'n bwriadu siarad yn Gymraeg, a dwi'n gobeithio bod pawb a'i clustfon. Diolch yn fawr iawn. Ac ar y cychwyn, gai diolch i bawb o gwmpas y bwrdd sydd wedi cyfrannu tuag at y sefyllfa i ni ynddi hi heddi, yn aelodau annibynnol ac yn aelodau gweithredol o'r bwrdd. Mae yna ysfa i sicrhau bod y sefyllfa yma yn rhoi mwy o gadarnhad i chi fel bwrdd cyfan o sefyllfa risg y sefydliad drwyddi draw. Felly diolch. Wedi dweud hynny, mae'r lefel cadarnhad yn parhau i fod ar lefel 2, gan ein bod ni'n gyd yn cydnabod bod gwaith pellach i wneud ar y gofrestr. Mae'r papur yn amlinellu y sefyllfa ar ddechrau y cyfnod adrodd, ac hefyd gyda diolch penodol i Rachel am ei gwaith fel cyfarwyddwr droso'r gwasanaeth canser, diweddariad o bythefnos yn ôl, neu wythnos yn ôl, dwi'n colli amser fan hyn, o safbwynt y gwasanaeth canser. Mae gan Ann ddiweddariad pellach ar y sefyllfa o ran risgiau gwasanaeth gwaed. Ein bwriad ni oll nawr yw rhoi proses gref mewn lle i gefnogi y math yma o adrodd yn ôl o hyn allan, a mae hynny yn cynnwys gwneud y cysylltiad yn gryf rhwng y gofrestr hon ac hefyd y TAF. Dyna'r camau nesaf ar ein cyferni. Mi fyddwn ni yn parhau i gryfhau y modd y mae'r risg yn cael ei adrodd i chi, gan gyfeirio'n benodol at rhai o'r pwyntiau gweithredu ni newydd drafod. Ond mae cydweithwyr o gwmpas y bwrdd yma yn hapus i ateb yn rhyw gwestiynau sydd gennych chi ar y gwaith sydd wedi wneud ar y risgiau. A hoffwn ni nawr falle gyfeirio at Ann i roed rhywfaint o grynodeb ar y sefyllfa o safbwynt y gwasanaeth gwaed cyn bod ni'n cael trafodaeth bellach.
Diolch yn fawr, Non. Ann, os gwelwch yn dda?
So as Non has said, what we've tried to do this time is to take the data of the board and work backwards to try and get the most up-to-date picture of the risk to share with the board today. Rachel did some very detailed work, as you can see, for VCS, and she did that, I think it was last week, just before the week before the papers went out. So that's as up to date as we can get that risk picture. Because we have a process in WBS that was probably more embedded than the VCS one, they stuck to their process from previously. We wanted to see how it worked for VCS, and we will now move to the same process for both the divisions. So in the paper that you see today, the risks for WBS were reviewed in mid-December. So that's why there's a discrepancy. And if the board is content with the process that we have in place for VCS, we will now roll that out across the trust.
Okay. Thank you.
Take any questions.
And so take any questions now. Oh, sorry, Lindsay. Wave or something so I'll see you. There's a nanosecond between me kind of doing that and then somebody turn the other way and somebody puts their hand up. But anyway, Lindsay, please.
I wanted to say I really welcome, and thank you again, Rachel, really welcome the work that's been done, because it gives me much greater assurance to know that the risks that are on here, it's not just about the update, but it's the risks that are on here are the risks we need to be looking at. And the fact that I think it's 10 risks have been reduced or removed, just gives me much more assurance that we're looking at the right things. And I think it was really notable then that some of the risks that are down for WBS are out of date.
Yes.
And so it's really, again, really welcome to hear that that same process is going to be followed there. So we should definitely be seeing seeing the difference. Just to note, and I know this was referenced at QSP, but for the next time it comes to us, so number 22 and 2249 on page 37, the risk level has been raised to 16, but that shows in the current risk, and it should be the inherent, it should be in the first column, because we've got a higher current risk, which shows our mitigations are making things worse, which I'm sure is not the case. So just the public record to make sure that is clear. And I know I've raised that before, but I think it's just really important. And just to say, I did also note that against, for example, 10 and 11, that the update date.
Did you say 10 and 11?
Yeah.
Thank you.
3270 and 3332. That the update date given in the column is still November. And so just wanting to make sure, are those updates getting caught up in the new process, so that we're not just removing risks that have been reviewed or reducing the score. We are giving some update.
Yeah. Yes.
Thank you.
Thank you. Gareth, I'll call you in just a moment, but as Lindsay has mentioned risk 11, I had a query in relation to risk 11, which is about, I think it's risk 11, or is it risk 10? Risk 10, sorry, as Lindsay's mentioned, risk 10, which is as risk to performance and service sustainability as a result of increased demand for SACT, starting to exceed capacity in all clinics, leading to the burnout of medical and supporting workforce due to excessive workload. And that's what the risks addresses. But I just wanted to ask, are we now clear, and Anne, I think I'm looking at you in relation to this, that all available outpatient slots are being used Monday to Friday? One of the reasons that there were capacity issues, that we weren't using every outpatient slot fully. There were some gaps.
Yeah, there are gaps when patients DMA, etc. What we're doing is, pardon me, we've done a recent audit, and we continue to do audits across the months and weeks. So there's a regular sequence of audits for outpatients to ensure that we get the utilisation correct.
I wasn't meaning utilisation in the clinic. Is that every Monday to Friday, morning and afternoon, is that all being used? Because it wasn't. There were some mornings or afternoons that weren't being used for clinics.
There's two particular slow times, if you like.
Right.
So the Wednesday afternoon and Friday afternoon.
That's right.
Any new recruits we are focusing their clinics in there insofar as we can with job planning. So that is a continued piece of work to do that.
Great, thank you. Because that should assist with the number of consulting rooms required. If we've got 2 extra that slots, it should help with that particular issue as well, shouldn't it?
And we're also doing spot audits around the place to make sure that because of the changing nature of some of the clinics, that we are utilising things to their maximum.
Thank you. That's really reassuring. Thank you, Anne. Gareth, please.
Diolch, Cadeirydd. Rwy hefyd yn croesawu'r gwelliannau i'r adroddiad sydd yn rhoi llawer o gadarnhad i ni fod pethau yn digwydd ynglyn â'r risgiau yma. Mae yna rhai sylwadau gyda fi os gai, ysgolwch yn dda, ynglyn â'r papur, ac yna rhai ynglyn â'r gofrestr hefyd. Yn gyntaf ar y papur, dwi'n edrych ar y dudalen 4 o 7 ar risg 21. Mae'r diweddariad fyna yn gweud was reduced during the reporting period, a dyw hwnna ddim yn rhoi llawer o wybodaeth i ni pam mae'r sgôr y risg yna wedi dod lawr yn ystod y cyfnod yma, ac fysa'n o gymorth dysyn ni'n cael mwy o wybodaeth na hynna yn y diweddariad, ysgolwch yn dda.
Risk 25, did you say, Gareth?
21.
21.
21.
In the cover paper.
And in the...
So that's covered in the appendices or the appendix. and there's a detail of why the risk was reduced there.
Ond Gareth, fe wnawn ni o hynna allan sicrhau bod y rhesymeg yn ogystal â'r sgôr yn cael ei gynnwys yn y papur yn ogystal ag yn y gofrestr.
Diolch Non. A dyna beth o'n i'n ofyn amdano, ie. Achos mae'n haws cael e mewn un man yn hytrach na gorfod mynd i wahanol fannau yn y papurau i gael y stori'n gyflawn. Ac wedyn ni, yn y gyfrestr ei hun, dwi'n edrych ar yr ail risg, sef risg 2187. Ac yn y golofn ar y llaw dde, mae'n dweud workforce plan completed Q3, but currently on hold. Ac dydyn ni ddim yn siŵr pam fod y gwaith yna ddim yn parhau ar y funud, yr rhesymeg pam bod e yn sefyll yn ei unfan. Ac wedyn ni, yr pwynt arall yw ynglyn â risg 22 sydd yn risg newydd ynglyn â'r y broblem ariannol oherwydd bod rhai o'r swyddi yma ddim yn para o bosib. Ac y pwynt cyffredinol yw fod nifer o'r risgiau yma yn ymwneud â gweithlu, a mae'n bwynt sydd wedi cael ei codi yn y gorffennol, a ddylen ni gael adroddiad sydd yn canolbwyntio ar y pwysau sydd ar y weithlu, ac mae hwnna yn berthnasol i lawer iawn o'r risgau yma. A dwi'n meddwl bod ni'n bryd ni gael y gwaith yna wedi cael ei gwblhau nawr. Diolch.
Thank you, Gareth. You're quite right. It is something that we've discussed previously, that when there are individual risks, and there are several in relation to one item, and in this case it's workforce, are we losing the overall impact of the scale of the risk to workforce in general? I think that's the basis of the concern. I don't know if one of the exec team want to pick that up, Sarah? Or Anne? Okay, sorry, Anne.
So there's two aspects to that. There's the clinical workforce, and there's the workforce, the non-clinical workforce, if you like. So the clinical workforce, we continue to recruit to any vacancies. In fact, for most parts with radiotherapy and in the radiophysics departments, those recruitments are on track. The recruitment that's on hold, the non-clinical recruitments, because we're doing a new way of working piece, and we are reassessing the roles that we need with that, moving into the new organisation, moving into the new facility. I'll answer your question, Gareth.
Sarah, thanks, Anne. Sarah.
Yeah, thank you, Gareth. So I think Anne's response is absolutely right in terms of the individual. But I think your overall point around workforce per se would be a good idea to pull those together and actually look across the piece of that. We do talk about that and have those reports to some extent come into QSP, but recognise that they don't come up to the board. And actually we will look at doing that for the next time. So I can work with Anne on that.
Can we record that as an action, please? And Sarah, will you be the lead exec for that? Thank you very much. I got Vicky and then Andy Westwell. Vicky, please.
Okay, thank you very much. And I would agree with comments that others have made about the significant improvements we've seen in the paper, which are gratefully received. I won't reiterate what we discussed in QSP because we had a very good discussion on it, specifically around actions specific to the risks and actually what can we expect in terms of mitigation. But I guess some of the improvements that we've all commented on highlights the fact that there are a number of risks that actually have stayed the same, don't appear to be mitigated. And I guess as a board, we need to have oversight of that. And what I would suggest is, benchmarking with other organisations, then actually, how do we, on a frequent enough basis, discuss the risks that haven't moved to agree actually how we progress those. So I just wanted some comment from Non really. Absolutely.
Can I, before you
Sorry,
answer
of
that,
course.
can I add to that? There are some risks in here which have been on the register for 3 and 4 years.
Exactly.
And I think that needs to be coupled with the point that you've just made, Vicky, if I may.
But that is the point. If they haven't moved, we need to understand why they haven't moved, and actually what are we going to do about it to make sure we have got specific actions that will mitigate those risks.
Thank you. None.
Absolutely. So Anne and I were nodding at each other. So in terms of the benchmarking, we are benchmarking not only with NHS Wales now, but there was a meeting yesterday with colleagues from Royal Marsden to understand how they benchmark. So Anne is particularly taken with the way they report risks. So as part of, that is now a part of our improvement programme, understanding how others are doing it. In terms of the actions and the smart actions, Rachel is in the process of putting lunch and learn sessions with, starting with the SLT at Velindre Cancer Service to ensure that there's an understanding across the board of what we mean by this and what it should look like. So that's another action that we're delivering currently. In terms of the static risks, we will get there, absolutely. So there is an action, an outstanding action for us as part of the audit committee's work to look at the whole of the risk register, to understand where we are in terms of duplication, to understand where we are in terms of static risks that perhaps are not quite reaching the threshold here. And in Anne's words, so that we can do a bit of an amnesty around risk and consolidate a better position across the board going forward. So a lot of activity in support of what we're doing at the moment. We will get there, and we do have smart actions for all of them, but we're not quite there yet. So very mindful of the comments from QSP in that context, and I'll make sure you're all kept up to date. Thank you.
Thank you, Non. I saw Andrew before I saw you, Stephen. So the order is Andrew, Stephen, Lindsay. That's the order in which I'm going to take questions, and then Chair.
Thank you.
So Andrew.
Thanks, Chair. So this is about trams specifically, which actually appears twice, but the one at the very end of the table, the last page, which is risk, this number 20. So it became a new risk register item, and one part of it appears to be closed. It makes me nervous to close action 20. Action 20 is about risk to this, of course, the trams being the national translating access to medicine service, which has been much delayed and has caused a lot of anxieties. So the risk 20 is about negative impacts on service delivery as a result of governance arrangements. So we've closed that on the basis that the CEX, I think that should be the CEO.
Yeah.
But anyway, so I presume that's David attending us, so that we're part of that national conversation, of course. But I think I'd prefer it if we had a one trams risk effectively merging 19 and 20. 19 is in the table above, because of course, you know, having David representing us, that's good, of course, and but of course the risk is here, the delays to the implementation of this, and that of course could affect us, and it relates as well, of course, to our move to the new hospital and all sorts of timings around that. So I think I personally would close that risk 20. I would have a merge.
And it's a high risk,
which includes governance and delays in delivery.
So Andrew, thank you for that. David and I and Non discussed this very issue yesterday, because there are two issues here. There is, will we be ready for 2027? But there's a lowering of resilience in our tram service now. So we've got an immediate problem and a possible problem going forward. And I don't know if you want to, because I know you've been having discussions and expressing concern. We did discuss also just putting the CEO will attend meetings. Good though that will be, we need to get underneath that a little bit, you know, to get assurance.
So I suppose building on Gareth's previous conversation about workforce, I think having singular risks that are more fully developed rather than multiple risks for the same area, you know, makes sense to me. And I would agree that while I will be actively working to mitigate those risks, that's not the same as being confident that those risks will be mitigated. So I would be comfortable with a single merged risk, which continues to be briefed on more comprehensively.
I think, and you've stolen my thunder. It's my role to raise trams, Andrew. You know that. But thank you for raising that. And we need to kind of make sure that it's not so much about process as about outcome in relation to trams. Stephen, Hillary, Vicky, is your hand down now?
Oh,
or you put it back up? Yeah. So Stephen, please. Then Lindsay.
Thank you, Jim. Actually, some of the question issues have already been covered, so I won't go over those. And they very much, as Vicky's intimated, the conversation today is in part a follow-on from a more detailed discussion at QSP. But I just do want to make a particular observation, a positive observation about, we've been asked about the format of the report. And it is something I think we raised at QSP. So when we look at the ratings themselves, the 25s, the 16s, the 12s, etc., I think the point we made was that some of those numbers can be calculated in two ways. For a 12, it could be a 3 times 4, or it could be a 4 times 3. So it was agreed that we would start introducing the actual calculations, and I can see that that has happened. So I very much welcome that. And for me, the point in raising that wasn't just to see the numbers as such, but as we know, there's the likelihood and there's the impact. And I think the point we were making was that maybe a set of actions to deal with the likelihood and a complementary set of actions to deal with the impact. So as we further develop this risk report, I think it would be helpful to try and tease out which are the actions which are impacting the likelihood and which are the actions which are impacting the actual impact itself. If you understand what I mean. So I just wanted to welcome. I'm hoping the point hasn't been covered. Just to mention, I did miss part of Non's introduction in Welsh, so apologies if we did cover that, but I worked out to switch the translation on. But what I'm finding now is as we switch back from the English translation of the Welsh back into the English in the room, there's quite a delay on my device, so I'm missing 2 or 3 sentences. So my apologies if this was either mentioned by Non or has been covered by somebody else. But I just did want to, for me, it's actually quite an important addition to the risk table. Thank you.
Non, is that okay?
Yes, absolutely. I didn't mention that, Stephen, so thank you for raising it.
So just before I call you in, Lindsay, I'm mindful public meeting. When I said it's my role to raise trams, that was a bit of levity. Just refer, so I don't want it minuted that it's the chair's responsibility to raise trams. That was a bit of levity because we got a bit of, every meeting now I seem to be raising trams as an issue. So I was just being a bit light-hearted. So yeah, our minute taker says she gets it, so that's fine. Lindsay, please.
Thank you. I just wanted to add to the point that Vicky made that Non addressed and absolutely acknowledging what Stephen's just said as well. First off, though, I'd like to say that I think it's really helpful when we're actually getting to the point of being able to look at content, what are these risks, and discussing the risks themselves. So I think that's been really helpful to hear more of that today. I'm then going to go back to talking about how we kind of understand what we're looking at. So it's a bit of seeing the wood for the trees kind of approach. The only dimension I'd add to what the two of you were saying is that there's something there for me about what's our risk appetite. And we've really got to be clear that if we are mitigating very close to where our risk appetite shouldn't be us to be giving it such a close look, because we're believing that gives us a reasonable, because it's always about reasonable assurance. We're never going to stop there being risks. But if we're still far away from it, so our target is 6 and we're still at a 20, then that should be where we're focusing our attention. Yeah. So there's just something about making sure we're taking into account our risk appetite and checking that that we all agree that is where we're happy to have our target approach as well.
Absolutely. We had a really good conversation about that last week, didn't we, about the importance of reviewing our risk appetite as an organisation on an ongoing basis. So yeah,
In
very
general terms, and
Yeah.
specific in
Of
relation
course,
to
yeah.
particular,
And-
yeah, that's
and
fine.
there's a training requirement there as well to make sure that all staff are clear about the differences and the ask.
Can't see any other hands up. So I've got 2 points I'd like to raise. One is in relation to risk 13, which is cancer associated thrombosis. The way that which the risk there is set out is that there's a concentration on process and not on patient harm. So Jazz, if it's you I turn to, or Anne, I'm not sure, but we've got potentially 2 staff leaving from a 3-staff team, and we know there's the serious risk for cancer associated thrombosis. So what mitigations are we putting into to avoid patient harm as a consequence?
Yeah, so I may not be as close to it as perhaps Rachel or Anne are, but certainly aware of the service, which is one of these it's an example of one of the services that we've taken on to lead, but actually may not necessarily be fully commissioned to deliver, however, have been doing it for years. And therefore, I suppose the responsibility lies with us to consider what the sustainability of the service is. It is sitting with the Palliative Care Directorate, and I know there are some active conversations and considerations for appointments to be made, certainly to replace the existing consultant who's led on it, but also to look at how we can consider sort of workforce transformation to help us solve it, because we can't rely on 1 or 2 individuals to deliver the service. And that's a very good opportunity to build in some multi-professional working as well. So I think that's the sort of high level position. I'm not close to any further detail that might have happened recently.
So we have, as Jazz says, one of our palliative care consultants is currently leading on the service, and we are reviewing that in relation to the retirement. And we've linked to an Aaron Bevan and colleagues there, and we're looking to provide a Southeast Wales service and to tap into that, so that it's a regional service. Yes, which will give us sustainability of the service and resilience in a way that a single provider doesn't give us.
Thank you. Just to note, there was a paper came to Shared Services earlier in this week about hospital-acquired thrombosis, which included cancer-associated thrombosis, and they have appointed a clinical lead for hospital-acquired thrombosis, and there are learning packages have now been developed and are available, and I will send to both of you.
We are aware of that. We are linked in to, well, the hospital-acquired thrombosis national or Wales piece and our response to that. I just did want to add about this particular service that it is actually a really valuable, Wales leading service, which is an opportunity as well for us to really think about how we want to position ourselves.
Absolutely.
And it's an opportunity to do it properly. We have research that is aligned to this, and one of our biggest recruiters for a study that was developed through the thrombosis service. So I think there's some work to do on actually not just addressing the person, but actually where do we want to take the service, and what should it look like, and how are we leaving it for Wales potentially. So those are the conversations that are also happening, but we might need to get around that.
That leads me to think that this is a much broader issue than just the risk that is here. And I'm just wondering whether a paper to Strategic Development Committee about the leadership role and how that needs to develop might be helpful. But you could decide that outside the meeting, perhaps. But the issues you've just mentioned are there, Jazz, are much broader than the risk.
I think there's an issue and the opportunity, as I see.
Exactly. And if we want to grasp the opportunity, then we need something to direct us to do that. So if you could decide.
Driving here is around sustainability of the service going forward.
Yes.
We have a plan for that.
Okay.
I think there's another issue that sits in there, which is that potential for a regional service. and we would build on that.
Thanks both for that. And my final comment is in relation to risk 15, and it's not about the risk per se, but I'm going to ask our chief exec to come in here, which is in relation to the sarcoma consultant. And we're advertising for that. And on here it says we'll advertise on Twitter. So could I just ask our chief exec to, David, if you'll just comment on the use of Twitter going forward?
Yes, so the NHS Confederation for Wales has recently published a position in line with many other NHS organisations across the UK, where they have taken an active decision for a variety of reasons to move away from using X, or formerly Twitter, as a medium for doing business. And so I've asked Non to take a review in terms of the overall position in Wales as to whether or not we should do the same and consider that at the board, perhaps at our next meeting.
Yeah, that's really helpful. Thank you. I'm looking around very carefully now to see if anybody else has got any other comments to make in relation to the risk register. We've had a very, I can't see any hands up, we've had a very detailed conversation about how the risk register has been developed and about specific risks. And so I do want to note in the minute the very welcome developments that we've noticed this time in relation to having an updated risk, where there's a delay between the report being produced and the board meeting. We've got those updates. So many positive improvements, and I'd like those noted in the minutes, please. Also with a kind of a plea to continue the work which will develop more specific targeted outcomes and so on. So just wanted to make sure we note that as well. So we're noting the risks in the quality and safety domain with a score of 12, risks in the other domains with a score of 15 and above, noting and welcoming the ongoing development of the trust risk framework, and noting the work underway to improve organisational management of risk reporting. I think this has been a really significant step forward, I have to say. So thank you for all the hard work that has gone into developing the register for us and for our patients. Thank you. So that takes us to 4.20, which is the trust assurance framework. And again, I'm going to hand over to Non as the director accountable for the risk register during the reporting period to present this item, which gives the board the opportunity to review updates to the trust assurance framework and the action plan for our next period. So this is 4.2. Just going to find it. Sorry, Non, please.
Diolch yn fawr, a mi wna i siarad Cymraeg ar ei amser I fel. Diolch yn fawr. Mae'r papur o'ch blaenau yn cyflwyno y safbwynt diweddara o ran y TAF. Fel soniais I yn gynharach, yr un peth dyw e ddim yn gwneud y tro yma yw, beth yw'r gair Cymraeg am ymlaen? Yw cyd-osod I hun gyda yr risg newydd a'r adroddiad newydd ar risg. Fe fyddwn ni yn gweithio ac yn gweithredu'r ddau bapur gyda'i gilydd o hyn allan. Fe gafon ni drafodaeth fuddiol iawn yn QSP yn waith yn rhagor, ac mi oedd na ffocws penodol ar yr cysylltiad rhwng y TAF a'r y risgiau oedd yn cael ei diweddaru hefyd. Felly mae hwnna'n ardal bwysig I ni edrych arni. Mae Lauren a Fynne wedi bod yn trafod y gwaith drafft ar gyfer yr TAF newydd yng nghyd-destun datblygiad yr IMTP hefyd, ac mi fydd y gwaith hwnnw yn mynd trwy'r broses gymerawdwyo dros y 2 fis nesaf gan ganolbwyntio'n benodol ar EMB ac yna SDC cyn dod atych chi fel bwrdd. Mae fy nghydweithwyr o gwmpas y bwrdd yma I ateb unrhyw gwestiynau sydd gennych chi ymhellach ar y manylion yn y papur, a dwi'n barod I gymryd unrhyw gwestiynau a sylwadau sydd gennych chi ar y broses hefyd. Diolch yn fawr.
Thank you, Non. Vicky, straight out of the box. Over to you first.
Just applaud again the work that's taken this TAF forward. So thank you to Non and colleagues for that.
I guess as we start to see more explicitly the actions that have been taken, it's actually how that translates into the controls and the assurances. And that's the part that I'm not seeing in the template. So we've seen lots of actions being updated, but that should, at a corporate level, have therefore improved controls and improved assurances. And that's the part, it's really helpful, Non, to see the red updated actions. So you can quickly go to the template, see what else there is. It's not translated into those assurances and controls. And I think that's the next bit that we need to be explicit as a board, because again, back to Lindsay's point, is actually, so what's the impact? How are we dealing with these risks and how we delivering the strategic objectives? So that's great. Yeah, we'll look on that.
So that would be part of the ongoing development. So agreeing with Vicky and that part of the ongoing development.
Yes.
Thank you, Lindsay, and then Gareth. Please, Lindsay, a scroll from that.
Thank you. I just want to look at the risk 7, tab 7. Sorry, just the template. The template kind of goes one way or the other when you scroll through the papers. Yeah. So sometimes I think I've kind of lost where it is. So I've just had a quick word with Jazz about this, and I know I thought about it around QSP, but we didn't reference it in the meeting, so I thought I would raise it here. That we've got an example here of where I'm not sure that we are identifying gaps in assurance or not. So we've taken on this one that the second line of defence is the executive and the third line of defence is board management, whereas in effect, both of those are internal and they should both be second line of defence. Which if you take it to be that, gives then the third line of defence that we have no third line of defence, and I'm sure we do, but it's not noted on the tab. So to me, that would be a real kind of red flag. Where do we get our assurance at the moment? It looks like we've got a massive kind of gaps in assurance in that area. I've had a quick word with Gaz, and that's something that
yeah, we'll agree with. So our third line of defence might be the benchmarking or quality standards that we can reference. I think this was the way we set it out in the beginning, and we need to, we've oversight really in the way that we categorise that. So we will address it for next publication.
And will that be for March's meeting?
Yes.
And who will own that?
Jazz.
Okay, thank you very much.
And Nick.
Okay, and thank you for raising that, Lindsay. That's an important point.
Sorry, I've just got one more. So I just wanted.
Yeah, sure.
So, and one of the kind of discussions that we've had, I think it was more through the governance and risk group, was just wondering whether the kind of utilising the 7 levels of assurance in the assurance ratings on the TAFs, because saying partially assured or not assured or negative assurance, it doesn't give much of a feel of where we are actually at in terms of that and how that reflects our gaps. So I was delighted to see that on tab 6 that Non has kind of started to use that, and I'd actually quite like to have the board reflection on, does that help us to understand what we're looking at a little bit more and how much assurance we're getting in each of those areas, but just to personally to welcome that.
How do you suggest we take that forward, Lindsay? Or Non?
I will take that on, working with Laura and thinking especially about how we map out assurance on this for next year, because we'll have one other reporting cycle in this format.
That's right.
So that's on our list of things to consider for next year.
So that will come June time. March, May. Yes, May will be a meeting. Yeah. Okay, thank you very much. Thank you, Non. That's an action for Non. Gareth, please.
Diolch. Dau bwynt ysgau sylwch yna. Y cynta ar dudalen 4 o 40. Ac yn ymwneud â taf 3 a gweithred 3.12. Ac just ar y gwaelod fyna, mae'n gweud due date moved to April 2026. Ac o'n i just yn amholi os honna oedd y dyddiad cywir, achos mae yn teimlo fod hynna yn bell iawn yn y dyfodol, a dylai a ddylen ni fod yn cael y gwaith yna wedi cwblhau ynglyn â'r cynllun cadw nyrsys cyn mis Ebrill 2026. Dyna'r pwynt cyntaf.
Can we take that point first, Gareth, and then we'll come to your next point? So is there a response to that?
I think
Anne? Are you pointing at Anne on, just for me to be sure?
that was Sarah. Is the executive
Sarah,
lead,
so apologies.
It's page
Your
4.
pen went that
Yeah,
way.
no,
It's assumed it's April 25.
it's page
Yeah.
4 of the cover report. I think is
Ah,
the
that's
easiest.
right. That's for the cover report. The one-
I assumed that it was probably April 2025.
Yes, it should be 2025.
And while we're on that, there's a similar one. Should we just pick up on?
Just
Yeah.
we note that for the minutes and for Gareth. Did you hear that, Gareth? That
Yep.
the date 5.
Diolch.
Thank you. On that point.
Probably on the top of page 6, which is where it says that data and insight formative paper due at SDC in February 24. So I'm
Okay.
assuming it's February 20.
25. Yep.
While we're on that.
Yep. We'll tidy this up.
Ag
Thank you.
diolch. Mae'r ail bwynt wedyn ni ar dudalen 6 o 40 yn y papur yn yr adroddiad ag ynglyn â taf 6 a gweithred 6.06 ag mae'r diweddariad fyna'n gweud activity ongoing, no firm date for completion. Fyse o gymorth dysyn ni'n gallu cael rhyw syniad pryd fydd y gwaith na yn cael ei gwblhau, os gwelwch yn dda?
Wrth gwrs. Wrth gwrs, yeah, Cnaf, yeah.
There are ongoing benchmarking, as it says here, but it's quarterly that the reports are done across the 4 nations. And my discussion with Alan was that we would bring those reports back here or through QSP in here. So that should read quarterly because it's an ongoing process, the benchmarking. So
Diolch.
Yeah, okay. Thank you. Thank you. Nikki, yes, it is Nikki.
Apologies, I was struggling to scroll with my machine.
I know. Those of you who are asking questions, just a plea. When you say page 5 of 60 or page 5 of, it'll take some of us a while to get to that space. And if you're talking, we're not then listening to you. So could you just give us a couple of seconds so that we can find the space? That would be really helpful. Thank you, Nick.
So if I could just take us back to the previous comment in relation to the April 26th and the implementation of the nurse retention plan. So just to give board assurance that the nurse retention plan was approved at the Executive Management Board. So that's now being signed off. But it's a comprehensive plan that we are now working through and implementing. So completion of that, it is anticipated to take us to April 26th, albeit a number of milestones will be met
On the
prior
way,
to that.
yeah, that's helpful.
The actual TAF action is the full implementation of that plan, which we anticipated will be fully completed by that time.
So I think that's really helpful information there, Gareth, in relation to your point.
Mae o gymorth, diolch. A be fyse yn helpu ni, tasyn ni'n cael diweddariadau yn y cyfnod yna, fod ni ddim yn gofod disgwyl tan Ebrill flwyddyn nesa.
Yeah. Of course. Nick is nodding, and Sarah, you've got your hand up in relation to that.
Yeah, thank you, Nick. You're absolutely right in terms of the full implementation. It's how we break it down within these actions, though, isn't it? So
Yeah.
it's a milestone action full in terms of the TAF for us to measure that progress. So we certainly, this is why I'm scribbling furiously in terms of breaking that down and making it more accessible then in terms of that progress.
Lauren?
Yes, so just linking to what Non was saying on format and approach going forwards, that will happen in the new approach because the actions to address the strategic risks will be in the IMTP and we'll have that quarterly tracking. So I know we're talking about this live, but just as reassurance across the whole piece,
that they will be one set of actions going forwards, starting in the May report, as we referenced earlier.
Thank you, everyone. Just pawb. I can't see any hands up electronically or in the room. So we're asked to note the current status and ongoing development of the trust assurance framework, and just to note also the action which will alter the format for the next for next year, for 25-6.
Yeah.
So we will have it in this format for the March meeting, and then it'll be in a slightly different format, which we look forward to seeing. And thank you for the development work that's going to take place to take us to that point. Thank you. Okay, right. 4.30, this is the performance management framework for November 2024. So Lauren, I'm going to ask you and whoever you want to call in to present this item. Take the Trust Board through the key performance issues and to note from the Flinders University NHS Trust Performance Management Framework report and supporting analysis for the reporting period. Lauren, can I hand over to you to take us? Can you bear with, when we're bouncing between points, it will take some of us a bit of time to get there. Just give us a couple of seconds, that's all, and we'll be fine. Thanks, Lauren.
Thanks, Chair. So the first section of the report is through the development activity that we've been tracking at Trust Board and colleagues around the table. We've been working on collectively together over the last number of months. A theme of that development activity has been to create the pyramid of reporting, as we've talked about for some time at QSP and at Board in wanting to get to. So just to remind ourselves where we are on that journey, the previous cycle of reporting, we switched to exception reporting. So that's been carried on through. And then there are two further developments in this cycle. So the first is the inclusion of levels of assurance for each part of the report. So the report for the summary of performance is broken down by division and directorate area. So there are 7 of those with separate levels of assurance that were approved by Executive Management Board and discussed in Quality, Safety and Performance Committee. And then the third element of creating that pyramid reporting is we introduced an explicit decision in Executive Management Board of were there any matters that we wanted to escalate to the Quality and Safety and Performance Committee. And the decision from the December Executive Management Board was that was not the case. Where there were exceptions in performance, we were comfortable that the accountable director was dealing with those in the way that we would expect. So we talked through that in Quality, Safety and Performance Committee, and hopefully it's straightforward because this is only on the first pages, so page 2 and 3. There's a detailed summary there of the discussion and actions that were taken in QSP across the main items that we discussed in the Flinders Cancer Service, the Welsh Blood Service, and for patient and donor experience. So that's what I was going to say on the development of the framework. So if there's no questions, I was pass on to Anne, and then Sarah, Matt, Carl and myself to talk through any of the sections on the report.
So Sarah, where do you, Anne first, please.
Thank you. So I'm not proposing to go through it in detail. Opportunity to read the information that we discussed at QSP. So I'm very happy to take any questions.
Are there any queries? Oh, Vicky, please.
I think just to applaud the progress that's been made with this report, because I think the clarity now that we tested out in the last cycle with 2 or 3 areas, which is very succinct on what the key issues are, the actions being taken, and actually, how's it going to be taken forward. So I welcome that. What I equally welcome is the agreement within exec colleagues in terms of the levels of assurance, which are very clear across all of the areas. And that demonstrates assurance about the ownership as well as the escalation of those key issues. So I think with that improved narrative, it's a really helpful document that takes you right to the heart of what we need to have discussions on, and we did so in QSP has been described.
It's been a feature of this meeting that we're just much less discussion on, can we have a column here, can we have a, you know, we're down into the content of the reports rather than the appearance of the reports. So so that's very helpful comments, Vicky, which I'm sure the team will take on board. Can't see any other hands up. Can I mention, please, in relation to find the page 12 of 38, with there's SAC non-emergency waiting times, and there's a graph there, a table, in which it sets out the month and the difference between unvalidated and validated performance. And at the bottom is a line which says we typically see a 16 to 20% increase in position following breach validation. I've calculated those figures, and typically you see about a 30 to 40% difference, because what you've done is assume that they're percentage point differences. Percentage differences are much increased, and so what that means to me. So, for an example, if I can just take you to one of the more dramatic ones, when it says 68.5 for November 24, and then it goes to 91%. That's a 32.8% difference. Not so you need to change 16 to 20 percentage point difference in the table, but nevertheless it raises another more substantial issue. Is it if the difference between unvalidated and validated in terms of percentage is so high, and it is quite high when you recalculate them all as percentages, what is that telling us about the initial data that we receive?
Well, so the initial data is based on a pure patients through the chairs. And what happens is we then go back and look at the clinical annotations against each one of those patients. Yeah. It's quite a laborious process. And there's a lot of repetition and duplication in that process of clinical teams. We're in week 2 of a 16-week program to design a cancer PTL, which will track this. And once we then say patient A is booked in for chemotherapy on that date, and if they are deferred, we will know the reason for the deferral. So we will automatically know what the position is. So in a few months' time, you will not see the difference between a validated position and an unvalidated position, because that will no longer exist. It will be real time and it will be validated.
So that is really welcome news. Really welcome news. If we can note that in the minutes, because what it was saying to me, if there's that much difference, you know, is there a problem here that we need to delve into? But you've answered that question for me, Anne. Thank you very much.
These figures.
That's really helpful. Thank you. Are there any other queries for what I might call Anne's section of the performance report? So who do you want to call in next, Lauren? Sarah, please.
So you'll see the highlight page on page 18 for workforce wellbeing and organisational development, and clearly then there is more data in terms of some of our equality data further down the report. The headlines here then our main 3 KPIs, you can see are steady state, really, I would say. We've got some key pieces of work that are beginning or ongoing. So if I can just talk about sickness for a second, the data to January, just to reinforce the numbers, is pretty steady state. It's 5.18% for the year to the 22nd of January. So it's a more up-to-date position we've got here, but it's still tracking at that similar position. What we have done in the last couple of months, and it is referenced here, is actually done that sickness deep dive, and some colleagues here that have come to QSP and so on will have seen that report. But very importantly, taking that to the next level is then triangulating a range of data and then working very proactively with managers in cancer services and blood services where we see there are red hotspots in terms of that triangulated position, so we can work with those managers to improve the situation. Because there are, key areas of high elements of employee relations issues, for example, high areas where we've got sickness absence, low PADR, and actually, if we put some targeted intervention into those teams, that should improve things across the board, which we know will directly impact on absence levels. So that's the approach that we're taking, which will take a little while to bear fruit, but that's absolutely key for us now going forward. With PADR, we have our new PADR policy, as it says here, and now we are trialling the new paperwork that accompanies that, the aim of which is to improve the conversation, improve the outcomes of that conversation, and therefore drive improvements, performance in terms of compliance with this target. And the early feedback from the trial is very, very positive, where we've had managers coming back to the team to say, this is making a really positive difference to the way I can carry out these conversations. So it is seeming positive at the moment. So I'll leave that there, but happy to take any questions, Chair.
Andrew, please.
Thanks. So could I just check on the staff sickness? This is where we have the national target and our local target.
Yeah.
And I can remember the discussions around why we did that. What would be really interesting is to know where other NHS organisations are in that metric, actually, because that gives us a sense of our staff, and their health and well-being. Do we have any comparative data from other NHS?
We do. There is a national dashboard which is published monthly, and on that scale we are doing very well in terms of our absence levels. In terms of the smaller organisations, we're probably doing less well, but that is because we are a clinically facing organisation, whereas most of the other smaller organisations are not. So it's hard to benchmark because we've got the massive health boards, and then we've got the smaller organisations which are doing other kinds of work.
Okay.
What we are now looking at is how we can benchmark beyond NHS Wales, actually, because that would be more helpful and useful to us. And we're doing that in terms of our individual pieces of work and our approaches, as opposed to benchmarking the headline figure at the moment. Yeah. But that is absolutely something we're talking about as a team now.
Yeah, thanks.
Thanks, Andrew, for the question, and Sarah for that report. Gareth, please.
Diolch, Cadeirydd. Rwy'n edrych ar y dudalen yna, sef dudalen 19 o 38. Honna oedd Sarah yn sôn amdani just nawr. Ac mae'r blwch ar y cornel llaw dde yn y gwaelod yn manylu y prif faterion a'r risgau. A dwi ddim yn siŵr p'ne ydy'r yn y blwch ar y llaw chwith mae'r camau lliniaru, a ydy rheina yn berthnasol i'r materion sydd yn y blwch ar y llaw dde, achos dyn nhw ddim yn I weld yn berthnasol fel maen nhw wedi cael eu ysgrifennu.
Diolch, Gareth. Atebwch, Sarah, please.
Yeah, thank you, Gareth. I understand completely where you're coming from with that. So the fundamentals of management training, which is what we refer to in the box on the left, in terms of the actions, directly impact on our capability and confidence of managers to effectively undertake people management, because our first area of focus for fundamentals of management is about management against workforce policies. How well are managers actually using our managing attendance at work policy, using our capability policy, using our other workforce related policies to help them manage their staff. And when we've actually worked with individual managers, we are now taking a coaching approach to help managers do that. What we've also discovered really is that some fundamental training would help get us to an elevated position in terms of people's knowledge and confidence. So I'm sorry, Gareth, that the way it's described doesn't directly link them. So you're absolutely right. We need to improve the way to describe the mitigation and the risks.
Diolch, os gai. Do'n i ddim yn siŵr beth oedd y cam lliniaru oedd yn berthnasol I ddim digon o amser gan reolwyr i allu wneud y pethau hynny yw y prif fater cynta yn y blwch yna. Ac y cwestiwn mwy cyffredinol am hwnni yw, a ddylen ni fod yn disgwyl camiau lliniaru ar gyfer pob prif fater sydd yn cael ei fanylu, a mae hwnna yn berthnasol i'r adrannau eraill o'r adroddiad hefyd.
Sarah?
So in terms of the general point, I think what you're saying is we haven't got an action or mitigation that directly relates to every point on the risks in the right-hand box. I think that you're right there, Gareth. There's no direct correlation between the number of in one box and the other. So we can certainly pick that up for this particular page. In terms of more generally, in terms of capacity of management time, this is something that anecdotally we hear from managers, that they feel that they don't have the time because they are stretched in terms of their clinical work, for example. So I don't know if any other colleagues here want to talk directly to that in terms of capacity. I think it correlates with a number of other things we're talking about today, doesn't it?
Yes, thanks, Robin.
Absolutely. And it's about managers feeling that they can take time out and have protected time to actually take on those line management activities. We know it's key and we know it pays dividends actually and improves the efficiency of the service. And it's how we break into that cycle to some extent, isn't it, and give people that opportunity.
So later in the agenda, the second part of the board will be going through that in more detail and how we propose to address.
Okay, so could you hold it till then, Gareth? I think that would be really helpful. So I'm quite Hilary, please.
Pwynt, nid ar y pwynt hyn sydd gyda fi, so oedden ni wedi gorffen ar y pwynt na, neu chi'n moyn I fi aros tan bod rhywun arall eisiau gweud rhywbeth?
I think so. I think we're going to come back to it later in the day, Hilary. So so Gareth's content with that, and so we'll come back to it. So Hilary, if you've got a new point.
Yeah. Diolch Gadeirydd. Ar tudalen 35 o 38, ar gwasanaethau digidol.
Yeah.
Yeah. So fi'n gweld bod nifer o significant IT business continuity incidents er enghraifft tipyn uwch na beth yw'r targed, ac hefyd bod ni dim ar targed gyda'n cyber security ac yn y blaen. Beth I ni'n neud I sicrhau bod ni'n gwella yn yr ardal na? Sori os dwi'n rhywle arall, bod fi wedi miso fe.
Carl, can I turn to you for that?
Yeah, there were two things in there on page 35. One of them we measure on a yearly basis against the compliance against cybersecurity. So whilst we're working very hard, we only ever measure it very rarely and present it back. So there might be a way of presenting that plan back on a more frequent basis, which would show the movement towards the target. On that particular one as well, when we did bring the last cybersecurity plan through the governance, we did make reference that we'd been moving to the cyber resilience unit, which is the NHS Wales way of measuring rather than the 10 steps. So we will see a change in the measure for that. But we are working against the cyber plan. It's just that we don't bring updates to it too frequently. The next measure is interesting, and that's the compliance with the cybersecurity statutory and mandatory training. Our target for that is 85%, and we're currently at 82 for this reporting period. I've just got the latest statistics from Bevan, and we're just over 82. So it's been a number of months before we've hit the mandatory training target for cyber. But to me, that's an interesting one because we would want our colleagues in the kind of organisation to be up to date with their mandatory training around information governance and cyber, recognising that there's a large demand on the service already in terms of mandatory training. In terms of the IT business continuity incidents, we did bring the report of that through the last QSP meeting. and we confirmed to QSP that there are no action plans outstanding for those incidents. So whilst the incidents are higher than we'd expect, or we'd want them to be with our target of 6, there wasn't any pattern behind them, and we've closed out all the action plans against them. They're made up of 2 things really. They're made up of local incidents, and in the on page, I think it's 20 of the kind of pack, we highlight one where we did lose power into one of our network equipment rooms, which caused a local incident. The majority of them are in there against national incidents managed by DHCW. And it's not to say that I would want to take those out of our figures, because digital is a service that I provide to the organisation, so it's really important. And colleagues in the organisation don't really care who provides the service, whether it's me or if it's DHCW. We still need to maintain that hard, and I say we are working hard with DHCW on those measures. There's a number of actions we're against the plans.
Just add to that.
Thank you, Carl.
Just 2 points to just as what Carl said. So 2 things. Cyber. I mean, that is the thing. And interesting, we had a exec management course run on Tuesday this week. All the days blended to one. And we're absolutely going to target that. So as a group, we've identified we're going to have a very short, focused plan where we understand where the gaps are in the cyber and target that. Myself and Carl are going to look at that plan, so we get that up very quickly. And the second bit, so it's then, I guess, Carl's point about very busy people. How do we make it easy for people to get their confidence up? I recently did the cyber data information governance training online, and it took me about 2 hours. So I think there's something important there on actually making it helpful for people to be able to do the training in bite-sized chunks, and that's a national issue. It's not a Velindre issue, so we're going to try and speak to colleagues providing that training. It's actually let's make it nice and straightforward for people to get the various training at the right times, and it's not the easiest thing to follow either. So 2 things. One, we're working nationally to try and make it more consumable. The second thing, as an organisation, we're going to come up with a targeted plan to get that number, not just up to 85, really. We're saying then that 15% of our people haven't had cyber training.
Yeah,
What does that mean?
and therein lies the risk.
Yeah, so we don't know what get under. That's probably not achievable, but let's really try and push as far as we can.
Thank you, that's helpful input, Carl. Stephen, I can see you, but you're number 2, so there must be somebody else's hand up somewhere.
It was Carl.
It was Carl. Okay, you're number 1 now, Stephen. So, Stephen, please.
Okay, thank you, Chair. And just, I suppose, with my other hat on, alongside being Vice Chairs, I know we all know I'm the IM for digital, so just to give the board perhaps a little bit more information in terms of the fact that I meet with Ian and with Matt probably every couple of months. I've had a meeting only, I don't know, a week or 10 days ago, and one of the key things we go through, amongst many things on the information governance agenda, is compliance with cyber security training and the risks to the organisation. So I do go through these things in a lot more detail. Just to echo Carl's point, one of the challenges is that the training as currently constructed takes, Carl, I think, has gone through it perhaps quite smoothly in doing it in 2 hours. For many individuals, it takes far more than 2 hours. So that's a challenge we've got as an organisation, which is not, of course, any excuse not to do it, but we are expecting to put our teams through a very long, lengthy and convoluted piece of training to get them appropriately accredited or qualified on that one little point. I just, part of the conversation I've had with Ian and with Matt is around perhaps focusing in on which areas the trust are at highest risk, because there may be individuals within the trust who present a very low risk in terms of cyber security, and they'll be within that, I don't know, 15%, 12%, whatever it is. So there is work in the background around trying to nuance, I suppose, where the highest risks are and ensuring we get the highest level of compliance in those areas. Because as Carl says, I think we're never going to get to the utopia of 100% of our staff being compliant. One last point on that, of course, is that we sitting around this table are also required to undertake this training. And perhaps a conversation with yourself, Chair, I don't know, there may be some of us who, if we check our own PADR, etc., we find we're not currently compliant. But one of the things Ian is suggesting, which we might want to think about as a board, is at some point having just a single session, a development session, and having the cybersecurity training, so we're all up to date. And that's something that Ian's, well, does roll out across various departments across the trust. So rather than individuals having to do it individually, groups or teams or entire departments can actually benefit from the cybersecurity training in one session. But obviously that needs careful arranging. I'm sure there's a lot more we could add. Thank you.
I think you and I have just dropped out of compliance very, very recently because we did the training together. I think it's a two-year cycle. So I think you and I have just dropped out. So that's very timely that you should mention that. And I personally, I think that would be a very effective way. I know Ian is very good at presenting the issues and making sure you concentrate on them and that you go through them. If it was possible to arrange that, and if you would agree that we could have a board training or an IM training so that we can all be trained at the same time and then we'll all be compliant.
We would put it in the board development window, maybe.
Yeah, that'd be good. Yeah, put it in board development. That's a good suggestion. Thank you. Thank you, David, for that. I've got some hands up. Is that in relation to the issue?
On that, say, in the February board development, we're doing that for health and safety in the same way. So it's a training session which will count towards the mandatory training in the February agenda.
I'm not sure if it's in the February. We'll have a look. I'll have a look to make sure. But yeah, point.
Well, okay.
Okay. Matt, please.
Yeah, Stephen's picked up most of my points because obviously, as he said, we meet regularly and we did talk through this issue and risk. Just to reiterate, though, Ian is providing focused training with Ken Oaten, who does the cyber bit, he does the IG bit, and they're focusing on the areas where there's higher risk and it's much more accessible. Because if you imagine frontline staff haven't got the opportunity always to sit down and do the 2.5 hours. Yeah. It took me 2.5 hours a year ago. I flagged it a year and a half ago to the group across Wales that's trying to rationalise it now. They are making progress. But in the meantime, as I said, the focused development sessions that Ian and Ken Oaten do enable you to get your compliance in half an hour.
That's excellent. And I think if memory serves, Stephen, when you and I did it last time, we did it in bite-sized chunks. So we did it over 2 sessions. That's right, and it was very tailored to us.
The cyber presentation, so the bits that are not necessary for that individual group. It's very focused there. So
thanks, Matt. That's really helpful. So if there aren't, if I can make one observation, if you'll bear with me, very quickly, I want to say I'm not surprised to note the improvement in user satisfaction with Digital Services Desk. I've had occasion to use them a couple of times just recently. It's quick, it's responsive, it gets the job done. And so I'm not surprised to see that there's 98 or 99% compliance. It has totally transformed in my experience. So from your sample of one, but the figures suggest that that's the same across the piece, doesn't it? And happy for you to pass that message on to the team. You know, I couldn't be more pleased with the support that you get, and I don't think it's because I'm the chair. So don't think that for 1 minute that it's because I'm the chair. Okay, so you know we're so quick, aren't we? And we write our job here is scrutiny, and so we pick up the things that we want assurance on. But it is important at the same time to be balanced and to note when things are going very well. And I think that service is going very well. So we note the performance management framework and the discussions that we've held will be noted, and the actions that we've agreed on will be noted. I'll talk to you. I didn't quite get where you were coming from with health and safety, Lauren, but I'll pick that up outside the meeting to make sure I'm clear. I'm not passing it by. I'll make sure I'm clear. So that was for the month of November 24. We note the progress against the 9 agreed work packages, the levels of assurance for each division directorate as agreed by the Executive Management Board and discussed and noted at the Quality, Safety and Performance Committee. And we also want to note that the Executive Management Board concluded that given the levels of assurance and following discussion on a number of the exceptions for this reporting period, there weren't any specific matters which were for escalation to QSP, nor therefore the Trust Board. The Executive Management Board agreed that performance exceptions are being appropriately dealt with by the responsible director. Thank you, everybody. So we come to, I haven't got a breakdown. Should we be having a break? Oh, yes, a bit later.
10:02.
After the end of section 4.
Yeah.
Have our HCW colleagues joined us yet?
Yes.
I'll say hello in just a second. Can I come to 4.40? Financial report, and over to you, Matt, please.
Yeah, thanks, Chair. So QSP committee had a good discussion around the financial performance report. They pulled out 3 particular areas which are largely focused in the exec summary. One was around the LTA disputes that started at the beginning of this financial year, particularly around Halzar, but also more generally around the lift to the LTAs. So those issues will be further discussed in the next IMTP round while they're ongoing. Clearly, because we're about to develop our draft position on the IMTP by the end of this month and into February. In terms of one of the new risks that was pulled out in terms of the income around the marginal activity performance on LTAs, that continues to be short of the target for this year. So we will be £800,000 short in this financial year. And the other point that was pulled out was around the IMTP. And obviously, I've mentioned the issues we had for this round into this financial year of not having passed through, or certain health boards refusing to pass through the value that was set out in the allocation letter to them. So I was asked to comment on where we thought that would be for the next IMTP. So initial indications are that it's more clear in the allocation letter about it should be unequivocal about pass-through. We did have a discussion at the last commissioners meeting. There was no dissenting voices there, but that does not mean the risk is completely mitigated until we have LTA signed without lifting.
So we're still waiting for confirmation.
Well, we're still going through a process of discussion and negotiation, and LTAs will go out to be signed for next year. So in terms of this year, though, forecast the balance on our revenue position. So our 3 main KPIs on finance, revenue balance, staying within our capital resource limit, meeting the public sector payment policy. Those 3 will be met this financial year. I'll take any questions. I should say one further risk for next year that has come to light only in the past week is around the SDEC. So you may be familiar with the SDEC bids that the organisation put in. So it's about the same day emergency care funding that one of the policy leads had in Welsh Government. So Welsh Government have indicated that funding won't necessarily be available to us next year. We're in negotiation with Welsh Government on that.
Is that now to Velindre or to the NHS in Wales? To Velindre, okay.
That is currently funding IO toxicity clinics and expansion of our electric care services. So we have had discussion with Welsh Government yesterday in our performance meeting, and we are in dialogue with them about understanding why that decision's been made.
Thanks.
So I
was just going to say that I think one of the challenges here is that these have been annual non-recurrent, but for a number of years in a row, which both creates a kind of precedent and a degree of expectation, but also there's a reality behind establishing the services when they were originally envisaged will invariably have been on a recurrent basis. You cannot upscale particular staff groups, on fixed term contracts. And even if you did, they would renew with employment rights within 3 or 4 years of extending that. So I think while Welsh Government might view this as non-recurrent money, I think the reality for them and the way they've dealt with it over a number of years is that we have engaged with it in current service development. And I think it's kind of revisiting the mutual understanding of the realities of being able to withdraw. It's perhaps a bit simplistic to viewed purely as a project that we switched off. And that's the challenge which they, I think, understood to take away in the conversations earlier.
So is that a risk yet, or it could, we keep an eye on it could become a risk?
Well, in my mind, it's an issue because they've actually
It's
sent
an issue. It's
emails
actually,
saying
they've said it's going to be withdrawn.
Yeah, so and that's why, you know, we're having urgent conversations. So I just want to point out what David said is true,
Yeah,
because
okay.
you know, when we went into this discussion with them, I made it clear verbally on multiple occasions in the meetings that, and the actual papers we submitted, the cases say in them, this is to fund these services recurrently, because actually some of it we'd done ourselves initially at risk on non-recurrent money. It's a bit like how we received funding with a charity on some of it.
Yeah.
And that's why I was saying quite categorically in the case and verbally, this money needs to be recurrent. So, because we're recruiting staff, extra staff on top of what we already had. As David said, it's a permanent contract. That's the bit that we just got to work through with them and say, well, but didn't you understand that?
So is there an action to come out of that we can, so that we kept it, or will just come through in your
The
final
ongoing
report?
actions that we're
Yeah,
taking
okay,
in negotiation and discussion with Welsh Government between the Director of Finance and others in the organisation and the service who are running the service, and the implications across Wales, certainly South Wales on this.
So, Sally, you all right with that? But yeah, thank you for to note that as the way forward. Are there any other queries or questions for Matt in relation to the finance report? Please, colleagues. Gareth, please.
Diolch, Cadeirydd. Matt, o'n i eisiau gwybod tyma bach yn fwy os gwelwch yn dda ynglyn â'r risg newydd yma, ynglyn â'r incwm ymylol, ag y ffaith fod e'n mynd i fod yn 700,000 yn llai nag o'n i yn disgwyl. Ag ydy hynny oherwydd fod y lefel o weithgaredd cancer yn llai nag o'n i'n disgwyl, ag beth yw'r rhesymau am hynny, oherwydd mae'n anodd credu hynna.
Sorry, Gareth, I'm not getting translation.
Yeah. No, I'm not either. I'm glad you just said that. I was going to struggle on.
All right. Okay. It's quite a technical question, so I'll revert to English then maybe. It's regarding the marginal income, Matt, and the reduction in what we were expecting of 700,000, and I think it's because, from what I have read in the paper, it's because of the cancer activity growth not being what we had expected. And I'm just struggling to understand that, given the context of the Audit Wales report about cancer services in Wales. They don't seem to match, and I note that you say you're going to look into this, but it just doesn't seem to correlate somehow.
I mean, I guess you need to look at it in the context that the contract is made up of obviously our key service areas, SACT being one. If you looked at the SACT, it is meeting the target and actually beyond it. So the target that was set there. So, and the same with outpatients, which would drive through the SACT treatment target as well. It's the radiotherapy bit where it looks to me that the target that we set in terms of growth in treatment activity has not been delivered. So the planning part of radiotherapy is, and that's partly to do with, I think, changes in the way services have changed during COVID and into the following years, and particularly around
this hyperfractionation you're talking about.
Well, that's part of the part of the issue.
Yeah.
But it's also something we need to look at in terms of how we're forecasting what demand planning information is coming out of the wider system in NHS Wales from health boards feeding into our planning work in terms of what is going to flow to us. So I think what I'm saying to you is part of the forecasting clearly hasn't worked, I don't think, in terms of the growth. And that's probably more so around the radiotherapy bit. The rest of it has. We just need to understand why that didn't flow through if there was a change in the way treatments were happening in terms of reduced activity on the radiotherapy treatment.
So
but we've also looked at accuracy as well. So it's not just about the targets. We have done a lot of work checking that we are capturing all the data correctly in terms of what we're reporting through to our commissioners and charging them for. And that did pick up some differences, but not to the tune of the gap we're seeing between the performance to date and the target we set ourselves.
So Matt, did I understand it? So in so much as hyperfractionation is a component of the reduction in activity, it seems to me very perverse that we've got a system measuring kind of activity. So for the benefit of the patient, they only have to come, say, 5 times instead of 20 times. So that's a reduction in activity. But there's work which is elsewhere in the system to support the patient being able to have in planning, for example, to import. So it's just that the work has moved over to this side of the pathway where the planning is much more detailed and take much longer. And then the result is the patient only requires, I'm being very simplistic here, but the patient only requires 5 fractionations. So it seems very perverse that that could be a reduction in activity.
I mean, there's kind of 3 proxies and we just need to reconcile them. The number of actual patients referred, I suppose, is probably the most material in terms of getting a section. Then the planning volume that's associated with them for the latest radiotherapy treatment. It may well be then that the delivery of radiotherapy treatments has changed materially. So if we're just measuring one of those 3, we may be misunderstanding the total volume of activity.
That's the, exactly.
So the contracted mechanism does measure all. What I'm saying is the target that the service set itself didn't reflect the switch.
So it's based on numbers of fractionations.
The intelligence or whatever process we went through, the target that was set was, in my mind, was clearly too high in terms of the treatment bit. Yeah, but the planning bit is fine in a sense. You know, there's more planning being done because it's more complex, isn't it? You've got to do 3-hour plans instead of an hour plan for a hyperfractionated patient, if not longer. And the contract currency will pick that up, and we're getting the benefit of the extra income because it's in a higher, more complex planning band. And the treatment is the bit where we're losing because it's basically reduced the number of treatments in terms of activity-wise, and we're losing income there. That's not what I'm saying, though. It's the target that we've set ourselves in an expectation we were going to grow our income by X amount. And I think there's something there that we need to do more work on. Make sure when we're setting targets and then spending money, because we set these targets, we can actually put in our financial plans an expectation we're going to get X amount of income that the service can then commit to new developments, because our commissioners don't fund everything. So we have to use this activity-driven income to pay for new staff or growth in capacity. What we did is we set it at 1.3 million based on growth percentages that clearly haven't come to fruition in certain parts of the service. So that's why I'm saying we've got to be much better and very prudent. I would suggest going forward next year about what we set for those growth targets and what we then decide we're going to spend against that income growth.
Thank
we don't
you.
end up in this position.
Thanks for that. I will need to come back to that to round it off in terms of the minute and so on. Andrew.
Yeah, so I appreciate the complexities of demand forecasting in the, you know, an evolving area like radiotherapy, and taking everything we said into consideration, but it does feel like an area where there's probably, well, there is all the same conversations going across NHS England throughout the rest of the week. This feels like an area where we could actually talk cross-border and get some help if it's not happening already at a wider UK level, because it's going to be on the same issues, and it's likely that, you know, that finessing of you know, that intelligence about future demand in this area. If it's not happening already, I suggest, you know, talking a wider UK level. I don't know if that may happen.
So Anne's commissioned a report which will provide information at a more a longer term level, I guess, in terms of public health stats, and that will help feed through this. But there are discussions that happen at an operational level from the cancer service into each health board. That's where, you know, on the immediacy of next year, understanding the pipeline of demand from each health board through the pathway from primary care into surgery, diagnostics. It's the information that should be flowing through into our forecasting, and it does. Something's just gone, I think, it's just gone wrong. So we just need to make sure that that process is robust, and we second check it, third check it, and make sure that we're all happy. The target we set in each service area is robust.
So, what's the risk to the bottom line for this issue, please, Matt?
Well, it's 700k.
Yeah, I know the amount, but what will happen? What's your prediction for year end with a drop of 700k? Still,
We said we're going to balance.
We're going to balance. Yes,
Yeah,
that's
why I said
the point.
Three KPIs will be met this year.
Yes,
It just
that's
means
right.
we've had to use obviously growth money that we could have invested into something else, because we've gone and spent money before, off the back of an anticipated income that we're not getting. So there's funding that we would have spent on maybe new services of 700k from our LTA uplift that we can't obviously spend this year. The same will happen next year if we don't actually do what I've said and make sure it's more robust. But it won't happen, because I'm not going to allow commitment of spend against the marginal income growth when I've seen this happen.
So, does Gareth, that all stem from your questions?
Yes, thank you. It's a complex formula and calculation, isn't it? I think it's unfortunate that we're going to have to spend, in inverted commas, £700,000, which we were going to use elsewhere to make up this shortfall. And I think it would be helpful maybe in a board development session, without getting involved in the detail too much, Matt, but just to understand how we calculate these. Who's responsible for pulling these figures together, I suppose? Do we get input from our commissioners in relation to it, or is it purely an internal estimation that we put in place? Because I think, and you've said you're not going to let it happen again. What we can't have is this happening on a recurring basis, as it were.
Yeah, the cancer service, as I said, are the operational team. They develop the target of what they predict their activity to grow by next year. That's done in conjunction with health boards, and obviously, as I said, the demand that they've got in their organisations and how that flows through. So this is purely a cancer service operational matter to start with. That then feeds into the contracting and LTA process, those targets. So that's the bit that's got to be right. It's that conversation and the planning work that they do in the cancer service. It's got to be as accurate as possible from the information they're getting from health boards, and understanding also the public health aspects, which will largely probably come through in future years, not next year.
So what I'm going to suggest is we are where we are, and we know what that means in relation to our statutory responsibilities for this year. Gareth has suggested that we need, as a board, to understand a bit more the way forward, and we'd pick that up in a board development session.
It won't be a LTA discussion. What I'm trying to say is,
no, that's okay. That's okay. But
it's about how a service is forecasting its activity.
We still need, but I think what we're saying is we need to understand it, and I think that's what Gareth is saying. So, if that's okay with everybody,
I think it's the assurance around how we are going to continue to predict and
exactly.
And I think that there's COSC. I'm thinking of the National Clinical Oncology Subgroup. I can't remember its exact title.
COSC,
has a responsibility to be setting standards for radiotherapy in Wales and working alongside with them to understand what these predictions should look like, and benchmarking, as I think Gareth has suggested, outside of Wales. I think this is really important because we need to understand that.
Might suggest there's an update later on the IMTP process for next year, and at some point, both I suspect either in board development and or further board sessions, we're likely to be revisiting or getting briefed on the 25-26 and the 3-year piece. Probably the work that's going on to better understand what lessons need to be learned and what the new forecast for these issues are looking like from the service for next year will play into that draft IMTP. And so it might be worth having a specific update on the reflections and whatever learning has emerged in order to inform next year, so that we can collectively reflect on whether we feel we have greater assurance that 25-26 is more accurate than 24-25 turned out to be, and just understanding the basis from which we might be being told that at a future event in February, I suspect, Lauren.
Yeah, I was thinking how the
Very helpful.
development dates have fitted into the plan, but yes.
We might even need an additional board development because we've set the agenda, so we might need, but we'll pick that up. So that's really very helpful. So we've had a very detailed discussion on those matters. So we note the content of the December 24 financial report, the year-to-date and forecast revenue outturn position and PSPP performance, the agreed position on LTA income for 24-25 from our commissioners, the position with commissioners on the contract rebase agreement, hold your breath, and the latest position on the LTA activity performance for 24-25. So that concludes the finance report section. Welcome to Peter Groves. Welcome, Peter. And
thank you.
Is Paige here?
Lisa.
Oh, Lisa. Sorry, Lisa King. Is Lisa here as well?
Yeah.
Lisa is on the call. Yes, she is indeed. Yes.
I am. Yes.
Okay, thank you. So what I'm going to suggest, colleagues, is we take your item next. It's not next on the agenda, but if we take it next, Peter, then if you and Lisa need to get away, we're not going to delay you longer than is necessary. So, colleagues, that means I want us to go to 4.70 on the agenda. And as I say, to welcome Peter and Lisa from Health Technology Wales. And this is the time of year when they present their annual report to the board. And we have that in our packs. So we've all had an opportunity to read that. So I'm going to ask Peter and Lisa to, however, Peter, you want to arrange this between yourself and Lisa, that I'll hand over to you. We'll have an opportunity for discussion following that. Peter, do you know, have you met our new Chief Executive, David Donegan?
Not yet.
I haven't yet, no, but very pleased to meet you, David, virtually.
And I don't think Lisa will have met you either, but so just getting the introductions.
Yeah, Lisa must have had a call. Yeah.
Okay,
Yes,
so Peter, if I could hand over to you, please.
Absolutely. Thank you very much, Chair, and thank you for this opportunity to present to the board on behalf of my colleagues at Health Technology Wales. Unfortunately and unavoidably, my colleague, Dr. Susan Miles, Director, couldn't join us this morning, but as you say, I'm delighted to be joined by our Senior Programme Manager, Lisa King. I'm going to be giving the presentation, but if there are any questions that touch particularly on Lisa's area later on, then she'd be very happy, I'm sure, to be involved in responses. So if we could go to the next slide, please. For the purposes and benefit of those perhaps observing externally who are less familiar with the work of Health Technology Wales, we are a national health technology assessment organisation funded by Welsh Government, closely affiliated, of course, with Velindre, and our responsibilities are to identify and to promote the uptake within NHS and Social Care Wales of medical technologies that are worthy, that offer particular benefit to patients and value to the healthcare system. And we do this by identifying technologies, undertaking evidence-based assessments, appraisals, publishing our national guidance on our website, but also subsequently auditing the uptake and adoption of our national guidance too. So over the next few minutes, what I'd like to do is just touch on activity over the last year, 2024, in regard to those core elements of our work. And these are all summarised in our last annual report, 2023 to 24, which was also published on our website. So if we could go to the next slide, please. So during that period of time, 66 different topics were proposed to HTW. These came from a variety of different sources, the majority from industry, but also other important sources included NHS Wales, Welsh Government, academia. For those that came through the NHS, as you'll see on the right-hand part of the slide, there was a variety of different geographical and health board locations this last year. I should express caution about over-interpreting annual data. We know this varies very considerably in terms of where our topics come from year on year. But in the top right-hand part of the slide, you'll see we're actually now in excess of 500 topics that HTW have considered over the last 7 years. Next slide, please. And when it comes to our evidence-based appraisals, we filter out from that now 500 topics, those that we've considered that are going to offer potentially best value to undergo much more detailed evidence assessment. And that process of filtering is undertaken by our independent advisory assessment group. So over the last 7 years, 65 topics have progressed to full evidence appraisal, and from these 44 national guidance documents have been published. The decision-making group for HTW is our appraisal panel, again an independent advisory committee, multidisciplinary in nature. It's an appraisal panel that I chair, and essentially we have 3 guidance recommendation options. We have the option of recommending routine adoption if we feel that the evidence around clinical and cost effectiveness is robust. And over the last 7 years, if you see on the right-hand part of the slide, about 16% of topics that we've done appraisals on have had routine adoption throughout the general population. 43% we've recommended so-called selective adoption, perhaps in subsets of patients as opposed to the whole community. And in about 41% of cases, we find that the evidence really isn't sufficiently robust to recommend adoption at all. And often in this situation, we recommend further research be undertaken. The important thing is that topics that come through appraisal end up with definitive and very clear direction about what should be done in regard to uptake and adoption within NHS Wales and Social Care Wales. Next slide, please. So just to review, over the last year, we have published 11 pieces of guidance, medical technology guidance, covering a really wide range of medical conditions, cancer-related technologies. So, for example, the use of liposuction for treating chronic lymphedema in patients who've developed this as a complication of treatment for breast cancer. The use of low-energy contact brachytherapy in addition to chemoradiotherapy for patients with early rectal cancer, the use of robot-assisted thoracic surgery for patients with lung cancer, but many other areas as well. For example, the use of digital technologies to manage wounds, the use of solution-focused assessment tools for patients with advanced and quite severe mental health problems in secondary care. In cardiology, the percutaneous implantation of sensors within the pulmonary arteries that can help maintain surveillance, but also prevent the development of complications which necessitate hospitalization. And also the use of potentially life-saving wearable cardiac defibrillators in some patients undergoing complex device implantation for life-threatening rhythm disturbances. And finally, extending to social care as well, the second and third topics in this list, social care guidance to support patients, particularly people with at-risk children within their family, to support them within the community when they're at risk of requiring non-home care. So next slide, please. As I've already mentioned, a really important part of our function is to audit the uptake, not just of our own HTW guidance, but also medical technology guidance coming from our partner organisation in England, NICE. Their guidance is equally valid for citizens of Wales as ours. So last year, we audited a total of 14 guidance documents, 11 of ours, 3 from NICE. We had a very good response, a gratifying response from health boards and also from procurement organisations. If you look at the middle part of the slide, the very high level results of our audit show that there really is a high level now of awareness of HTW guidance, 79%, with an even higher level of clarity perceived by care providers in regard to our guidance, 96%. And also it seems a very high level of impact on local decision making around the use of medical technologies. So some very positive messages. We did identify really helpfully some barriers potentially to adoption, and in the next slide I'll talk about that in a bit more detail. Next slide, please. One or two uncertainties that emerged. The remit of HTW, we are not a commissioning funding organisation. I still think there's some uncertainty within the community among some health boards about that. So some variation, if you like, on the relevance of our guidance between organisations. And I think this is probably explicable by the fact that the health boards vary considerably in terms of the kind of geographical siting and the nature of the services they provide to their local communities. But we did highlight some important barriers to adoption, funding, resource challenges, relatively small patient numbers to be considered for the use of some of these technologies. But really gratifying to see that in only the minority of cases were organisations not aware of our guidance. Next slide, please. So if you just focus perhaps on the top three parts of this slide, you'll see from left to right the results, high-level results of our audit reports from 2021 all the way up to 2024. You'll see a very gratifying year-by-year increase in the levels of awareness and clarity over those years, and a high level of impact which has been sustained over the last year. So this exercise is one that is greatly valued by Welsh Government, and I think by Health Board colleagues as well. I think it's important to note that this type of methodical year-by-year audit undertaking is something that we at HTW are probably the only HTA organisation in the world that has been able to achieve this, and we're very proud of the results. Next slide, please. So, Chair, I know you're very aware of the breadth of the work that we undertake at HTW, which I haven't time to touch on, but is summarised in our annual report, covering, for example, collaborations with other HTA organisations nationally, internationally. But there is one piece of work that we undertook in 2024 that I'd like to draw to the attention of the board. So in spring last year, Welsh Government commissioned Health Technology Wales to undertake an evidence-based review and to prepare a report on that evidence, which we did submit in December of last year, looking at the way in which medical technologies are assessed, utilised and adopted within Wales, and considering how this might be improved potentially for the future. This was a collaborative project. We engaged with more than 180 stakeholders, including partner stakeholder organisations, both from within Wales and from other parts of the UK. Our final advisory report was submitted, as I say, in December, and comprised 22 recommendations for the future direction as to how we could, within Wales, optimally utilise, uptake and assess medical technologies for the future. Important recommendations around areas such as collaborative working and how this might look in the medical technology ecosystem. The importance of really impactful topic identification at the outset that is going to be needs-led. The importance of patient safety, of course, always important as a governance element of the use of medical technologies. The central role of patients and public involvement within this sphere, equality, diversity, sustainability. So a really broad report from which we were able to conclude that there really is enormous potential for Wales as a country to lead the way in terms of the utilisation and optimal assessment of medical technology. We see great promise for the future, and as an organisation, we're very proud in report in an evidence-based way to be able to kind of give pointers as to what the future might hold and how we can achieve that objective of being a nation that leads the way in terms of medical technology use. Next slide, please. So to conclude, I'd like to finish by acknowledging and thanking my colleagues at HTW under the directorship of Dr. Susan Miles for all of their expertise, their hard work, their true dedication to the work of HTW, which continues. This is the last time I will be presenting this report to the board. My tenure of 7 years comes to an end in April. So Chair, I also wanted to take the opportunity to thank you personally, but also thank your executive colleagues for the very strong support that you've given to our organisation over the last 7 years, during which I've been chair. So thank you for that. I think that's a really important part of the success that we've achieved over that time. So Jock, thank you very much indeed. I'd be very happy to take questions, as will Lisa. So I'll open it up and back to you, Chair. Thank you.
Diolch yn fawr iawn, Peter ac Lisa. Another busy and effective year, I think it is fair to say. Thank you for your comments, which I'll come back to at the end. But before that, are there any queries, observations, questions? Andrew, please.
Peter, thank you. I always enjoy your annual summaries of the good work that's going on, and sad to hear that you're coming to the end of your tenure. Just wondering, when you were talking about the implementation of recommendations, I was thinking about the Life Science Hub Wales here, because they are a facilitator. You know, they're linking Welsh Government with industry, with university sector, with others, to really facilitate those health, those life science innovations, I guess. Could you just elaborate on how work with them in terms of that implementation piece? Because it feels to me as though they're really critical to that, given particularly their industry links.
Yes, thank you very much. A very pertinent question. And I mean, firstly, to say that we have a very close working relationship with colleagues at the Life Sciences Hub Wales. We have a memorandum of understanding with them. We hold quarterly meetings with them to talk about our collaborations and work together. And you're quite right. The whole area of implementation and adoption is one of those areas of important collaboration. And other elements of the ecosystem as well. The Bevan Commission have done a lot of very good work around ways in which spread and scale of medical technology adoption could be effectively done in Wales. So this is one area where I think you rightly highlight that close working together, collaboration is essential, and speaks to some of the recommendations that we've made in our report to Welsh Government about how establishing that framework that focuses on avoiding duplication, but finding areas where we can all work together, setting in place mechanisms of really effective interaction with those who deliver services. This is one area where I think further work needs to be done. But in the meantime, please be reassured, yes, we have a very close working relationship with our colleagues. We share work programs, and they understand what we're doing, and we them, so that we look for these opportunities to really push the implementation and adoption agenda together.
Thank you.
Thank you. Thanks. Jazz, please.
Thank you, Peter, for presentation, and I agree, it's always great to hear the good work and progress. And what we can see in this report is that the scope for Health Technology Wales has grown, and great to see the PPI involvement and involvement in AI assessments, etc. And I know we've had conversations around the medical directors table. But one thing in the presentation, one of the adoption case studies that you demonstrate is just showcasing the use of AMAT software. And of course, you funded us a couple of years ago with a small pot of money to just have a look at the system and test it. And in fact, it's become a significant part of our infrastructure now, hasn't it? And Nick's nodding in terms of how we collect, report against clinical audit, but also in the quality and safety space, many of our kind of tracking systems and monitoring up of actions, etc., we can do effectively through that. So really just reflecting on how that's become part of our practice. But also really great to see the PPI group work that you did with our Velindre patient engagement groups and on the use of AI. So actually I wasn't aware. And it would be good to perhaps find out a bit more about all of that and how we can how do we build on that really with our group. So yes, I just wanted to flag those two things. Thank you.
Thanks, Jazz.
Thank you, Jacinta. And just to respond very positively, we were, yes, very grateful for that opportunity to work with you and your colleagues, and be reassured that that work has already inputted into elements of our guidance programme, and we have referred to it on 2 separate occasions during kind of generation of our national guidance. So that public patient involvement engagement exercise is already proving crucial, clearly a critical element in the use of AI technologies and how they fit with people's needs and the needs of the care and health system as well. So yeah, thank you very much indeed for drawing attention to AMAT as well. We're delighted that you're utilising it so effectively and that we were able to play a small part in pushing things forward there. But across the whole of the adoption audit, you should be aware that AMAT has been adopted widely amongst other organisations too, and has really meant that the quality of this work could be greatly enhanced. But thank you for drawing those 2 points out.
Thanks, Jazz and Peter. Point that I would want to note, Peter, that in the last year, 2 years probably, you've become a regular and a routine fixture at the chair's peer group meeting, and I like to think that that has helped to communicate the importance of HTW and what it does across all NHS organisations in Wales. And I know you were there about 8 weeks ago at chair's peer group. I wasn't able to attend that meeting. I can't think where I was, but and that your reports are very well received there.
Thank you.
I just wanted to make a note of that. And if there aren't any other queries, what I just wanted to say, Peter, that this will be your as this will be your last meeting. I just made a few notes in terms of my reflections on your tenure as chair. So since you have been chair and since I've been here in Velindre, I've been very pleased that very close working relationship that has developed with Velindre, and that's evidenced through the number of bids that go forward for appraisal. You know, our committees working together. Jazz, I've been very pleased at the way HTW is not only hosted, if you like, by Velindre, but it has become integral to the work of Velindre, and that's been very pleasing to watch under your leadership. Also under your leadership, the scope, as Jazz says, of your work has grown to include relationships with health technology assessment agencies worldwide, including receiving their imprimaturs for your work. So not only have they agreed to work with you, they've acknowledged the quality of the work that HTW undertakes. Can't read my own writing now. It has been, as noted, under your leadership also, patient and public engagement has really strengthened and developed, and that's been very pleasing to note. And of course, under your tenure, the first ever adoption audit was carried out, and we all were kind of, who's going to be bothered to, you know, to complete this? You know, people are very busy and all the rest of it. But through good communication and so on, these adoption audits have now also become routine and are providing us with very important information about you know, the work that you've done and its implications for practice is providing us valuable information. So those are some of the key issues that I've reflected on, that I've witnessed under your tenure as chair, and want to thank you for that, Peter, for the excellent leadership that you've demonstrated in all of these areas, and to wish you well as you move on to pastures new or back to pastures old, or whatever it's going to be, to thank you for your immense contribution and to wish you well for the future.
Chair, thank you very much. Those comments mean a lot to me. Thank you for highlighting some of our great successes. As I've already mentioned, our relationship with Valinda has been integral to our success. So once more, thank you to you and your colleagues for the support that you've given and continue to give. I think our organisation has a very bright future, and my final point is that we are a very strong team, and all of the achievements that you mentioned and many more can only be recognised because of the strong teamwork that everybody works together to push forward our agenda. And so I'd like to kind of finish by acknowledging and thanking my colleagues again for the support they've given to me over the years. So many thanks, and I wish you and HTW well for the future.
Thank you very much, Peter. So I can't see any other hands up. So we receive and note the Health Technology Wales annual report. You've discharged one of your last duties is to discharge the requirement to present this report to us, which has been very well received. And if you and Lisa now need to go, that's absolutely fine, because we've got quite a few items left on our agenda. And I hope our paths will cross, Peter, in the future. I've enjoyed very much our 6 weekly meetings that we've had, which have been mutually, I think, very beneficial. And yes. Reiterate to wish you all the best going forward.
Thank you very much indeed. Thank you. Goodbye.
Thanks, Peter. Thanks, Lisa. Colleagues, we're very close to having a break. I've just got a few items. Can we go back to 4.50, which is the Public Quality Safety and Performance Committee highlight report, which Vicky, you're going to present this item.
Yeah, and I don't intend to take any time. A lot of the issues that came up in QSP we've discussed through the papers that have come to the board. What I would say is that we're really a bit like the TAP and the risk register, where we've discussed at the board today some of the improvements in terms of how we're taking that forward. Equally, the policy assurance, which we've spent quite a lot of time in QSP about talking about the information that we needed in order to gain assurance. And the paper that came to the paper in QSP was the first time we've seen all of the information we needed from which to have an accurate record of our policy management across the trust. So that was very much welcomed. But otherwise, we've included a lot of the information we've already discussed at the board, but happy to take any questions.
And are there any questions for Vicky? Thank you for the quality of the report, Vicky, as always is the case with yourself and with that team. If not, if there aren't any points to raise, we note the key deliberations and highlights from the meeting of the QSP committee held on the 16th of January. Thanks, Vicky. I am going to suggest, I know your item's next, Nick, 4.60. I think we need a break. So I'm going to suggest a 10-minute break, no more than 10 minutes, please, colleagues. From an orderly queue outside to the loo or wherever, and we come back in 10 minutes. And once we've done the staffing report, I think we're almost into the consent section then, and we should move very quickly through the rest of the agenda. So 10 minutes, please. Come back at 12:35. Thank you.
Thank you.
Take this off. You put it on.
do you have to do?
Wait for that screen to go.
Yep.
Right. Okay. Croeso nôl pawb. Welcome back everybody. We haven't got that much of the agenda to get through. So if I can take us to 4.60, which is the annual presentation of nurse staffing levels, which we require to report on this annually. And this report, if approved today, will be forwarded to Welsh Government, as I understand it, as part of the reporting cycle. So Nick, if I can hand over to you, please, to talk to this report. Thank you.
Thank you, Chair. Given time, I'll take the report as read. Just a couple of things to highlight. We only have one area that fits within 25B of the Nurse Staffing Levels Wales Act, which is the first floor ward. No reportable harm and an appropriate establishment on that ward, so no harm as a result of nurse staffing levels. The appendices that are attached are the documents that will be submitted to Welsh Government. They're on a preset format. We do review the establishments every 6 months, so we go through it looking at a number of indicators to determine whether the establishment is appropriate. And we're currently working on a ratio of registered and healthcare support worker of 65 to 35%. But pleased to note that.
So Nick, could you just point out the report doesn't suggest it's more 50-50. So I know we've had this discussion, just to explain to everybody how you've come to a fantastic figure of 65-35.
The actual establishment as required to be documented is staff that are actually providing hands-on care. There's a coordination role, so that's a band 6 coordinator that is not included in that ratio or calculation. And of course, then there's the board manager as well.
So there's 2 extra whole-time equivalents.
Not on every shift, but on a day shift, you've got the band 6 coordinator who organises and facilitates across the floor.
So, colleagues, just to let you know that the best practice, evidence best practice is that a 60-40 ratio is the best practice, and we exceed that.
And we look at obviously what are the duties that needed to be undertaken clearly within the ward. There's a lot of care duties, but in addition, there's a lot of medication duties, control drugs, and high level nursing intervention required given the specialties that we are caring. Any questions?
Are there any questions? Or Nick, there's if I can put it like this, what's not to like? In this report. So I'm very pleased that the ratio has turned out, when you include legitimately the band 6 and the band 7, that the ratio of registered to support worker has come out at that. That gives me great assurance. So I'm looking around the room. I can't see any hands. And is Gareth still with us? Because he's been on screen, but I can't see. Oh, yes, he's just okay. So thank you for producing the report and all the hard work that goes into it, and also the hard work that goes into making sure that we're compliant with the requirements of 25B. So we note the report and having noted and approved it here, that it will go forward to Welsh Government. Nick, thank you very much. So now we come to section 5, which is planning and strategic development. And the first item, 5.10, is strategic planning update. So Lauren, you're presenting this item to give us a bi-monthly update on key strategic planning matters, which will be going to SDC, Strategic Development Committee, and to Trust Board members. So over to you, Lauren. Thank you.
So the report covers 2 matters for this period. So the integrated medium-term plan, 211, the list of guidance, national guidance, CABSEP priorities are included for note for the board that we've been working through over the course of January to include in the first full draft of the medium-term plan. And then 213 notes the process in which that will go through now with Executive Management Board, and then review through Strategic Development Committee to the Trust Board at the end of March. So into paragraph 213, we will, I will David and Matt to reflect the conversation we had earlier in terms of the board time on the demand assumptions and how we have time as a board on that during the process as well. Then the second matter is on the development of the Regional Cancer Programme and the Regional Cancer Programme Board. And as we as I referenced in the last couple of cycles, the appendix is a document which the directors are planning across the health boards as part of this South East Wales programme. So Cardiff and Vale, Cwmtaf and Arran Bevan share with their boards in the public domain to cover all of the regional programmes. So this is making sure that we are consistent in terms of that transparency of reporting. And the oversight board for the work approved that the rating for the cancer programme be changed from red to amber in the December meeting, which is reflected in this update to reflect the progress that had been made since October on the cancer programme.
Thank you, Lauren, very much indeed. Just one query from me, just for assurance. It's in the report. We're on track to have completed the IMTP by the end of this March for submission to Welsh Government. And that will and that report, when it is produced, addresses the planning guidance that came out in December. The necessary alterations or modifications will be included in the report that goes in on the 27th of March.
Yes, and to cover some key examples of those Cabinet Secretary priorities on women's health and children and young people.
Yeah.
We provided an update in the performance meeting yesterday with Welsh Government colleagues and reflected the way in which those will be included in the IMTP. And they were, the feedback was good, and they were supportive of how we were addressing those set priorities in the way we described yesterday.
That's good news, thank you. So, any queries or observations for Lauren in relation to a strategic planning update? This brief paper covers a huge amount of work. You know, I am very much aware of that across the whole trust, the divisions across the whole trust. I don't think there's any queries for you, Lauren. I can't see any. So, so we're noting the update for assurance purposes. It'll come to the next board in March in its final form.
The integrated, yes. So the 20, the date is 27th, is it?
Close to the
7th of March board. The submission then on the 30th. On by the 30th.
My computer's shutting down.
That's following going to STC.
Go to STC first. Yes, yeah. So STC will see it. We could circulate it to board, Lauren, so that if board colleagues have got any comments as well, the board members who aren't on STC, and then we would be ready for the 27th of March submission date. Thank you. I've been very careless and I have not had my computer powered up. So I have all my stuff here. That's all right. So we now come to section 6, to the consent items, and we've got 4 items for approval and 8 items to note. So before we start to sign these off, does anybody want to bring anything out of consent into the agenda for discussion, please? Oh, somebody's got to help me. Oh, thanks, Carl. Thank you so much. No? Okay, so I'll just take us through them. That's very, I think that might be a first where we haven't had to bring anything out of consent, so that's excellent. So, items that we are approving today, out of the 4 items, is the Chair's Urgent Actions Report. There was 1 urgent item of business for the Trust Board that was considered by a Chair's Urgent Action during the period, and this was in relation to the high voltage intake building. And so we're asked to ratify or approve the Chair's urgent action taken between 22nd of November, 23rd of January. Commitment of expenditure exceeding the Chief Executive Officer's limit. There was one item of expenditure required for Trust Board approval during the period. That was to do with the courier services for samples at Welsh Bone Marrow Donor Registry and the National External Quality Assessment Service for histocompatibility and immunogenetics, which is in the appendix to the report. So we are asked to authorise the Chief Executive to approve the award of the contract summarised within this report and supporting appendix, and authorise the Chief Executive to approve the requisitions for expenditure under the named agreements contained in the papers. And then 6.13 is the budgetary delegation, amendment to the delegated financial limits of the Chief Executive Officer and the framework for officer financial limits. So we're asked to approve increasing the delegated financial limit of the Chief Executive Officer from 100 to 500k, and to note the proposed delegated financial framework and indicated financial limits to be provided to officers of the Trust below that of the Chief Executive financial limit as set out in the Trust SFIs. So that's approved. And then there are a number of, under 6.14, Trust policies for approval. Employing ex-offenders and people with a criminal record policy, medical and dental terms and conditions annual leave policy, NHS Wales job evaluation policy and procedure, NHS Wales pregnancy loss support policy, and NHS Wales procedure for recovery of overpayments. So we are asked to approve those policies. And then under items for noting, we've got the Public Audit Committee highlight report of committees held on the 17th of the 9th and the 12th of the 12th, 24. We've got the Public Strategic Development Committee highlight report of the 22nd of October, 24. Public Transforming Cancer Services Programmes through Scrutiny Subcommittee. We've got the highlight reports for several meetings here, September, October, November and December. The Local Partnership Forum highlight report for December. Remuneration Committee highlight report for November. The Trust Seal report, a fixing of the Trust Seal, I love that term, for the period between September and November 24. The Health and Wellbeing Champion annual report. Thank you, Stephen Harries and colleagues for producing that for us. The Academic Partnership report. This is the first one in this format that has come to this meeting. So I think it's a very useful summary of all the academic partnership working that's taken place during 2024. Thank you, Nick and the team, for producing that, so we note it. The date of the next meeting will be Thursday, the 27th of March. I have been informed of one small item of AOB, which I'm going to ask Nicola to talk to, please.
So just wanted the board to formally note the consultation that's commenced within Cardiff University in respect to the future provision of pre-registration nurse training. It was something that it came as a surprise, just to assure the board that we are putting steps in place to support those students that we currently have in place, and looking for the board just to be aware that as a group of executive directors of nursing across Wales that we have met, we are discussing this, and we will be feeding into that consultation accordingly, because clearly it will have an impact on the provision of pre-reg training across Wales. But we'll also be looking at, okay, so what do we need to do to ensure that those places are met across Wales in the number that we require to sustain our workforce going forward.
Thanks, Nick. That's very assuring about our existing students, because they'll be disconcerted, so to note that support has been wrapped around them, I'm very pleased to hear that. And there will be lots of conversations. This is a very fast moving feast. I'm not quite sure what the final outcome will be, and we might pick up some issues later this afternoon, Andrew. So I would therefore like to close the meeting by thanking colleagues for your contribution today. But just finally, before I do so, does anybody want to make any comments about any item on the agenda that we've been through today that perhaps they missed the chance while we were in full flow in the meeting and you might be sitting there thinking, oh, I wish I'd raised this, or I wish I'd said that. Final opportunity before I formally close the meeting that anybody could raise an issue that they feel compelled to. If not, I ask the board to adopt the following resolution: that representatives of the press and other members of the public be excluded from the remainder of this meeting, having regard to the confidential nature of the businesses to be transacted, publicity on which would be prejudicial to the public interest, in accordance with section 1(2) Public Bodies Admissions to Meetings Act 1960 and paragraph 67. And for the public to know that at our private session in part B this afternoon, we obviously be ratifying the minutes of the last meeting, going through our action log, looking at Velindre Cancer Services structure, electronic prescribing and medicines administration, and we'll be looking at the private committee highlight reports. That's the agenda for the private meeting of the board this afternoon. I'm looking to our Director of Corporate Governance to tell me what time part B starts.
2 o'clock.
2 o'clock. So 2 o'clock, please, and you will need to log on to the private meeting of the board at 2. Thank you, everyone. We finished on time. Brilliant. See you all later on.